Hello and welcome again from London. Welcome chairs to AHP afternoon sessions. My name is Adam Guralczyk. I'm consultant surgeon and bariatric surgeon in Homerton. I wanted to welcome moderator, Ms. Rachel Aguilo, consultant surgeon and bariatric surgeon in Homerton. Our chairs now with this session is Emma Little, bariatric dietitian, Tamara Puplampu, bariatric dietitian, Mary O'Kane, consultant bariatric dietitian, and Dr. Manisha Sharma, consultant bariatric specialist. First on the session, topic Dare to Dream, weight loss exercise journey, presented by Jennifer Smith, our bariatric physiotherapist in Homerton Hospital, with vast experience in physiotherapy and active member of Physiotherapy Obesity Network, who brings together physiotherapists in tier 3 and 4 in bariatric surgery for better practice and knowledge exchange, and contributor to our Homerton Obesity, Bariatric and Metabolic Surgery book. Jennifer Smith.
Hi, can everyone see that screen? Can we see the screen?
Yes,
we can see your screen.
Okay, good. Hi. Hi, so my name is Jennifer Smith, and I am the specialist bariatric physiotherapist at the Homerton Hospital. Today, I'm just going to talk to you about my role in the service and as the bariatric physio. I'm going to talk a little bit about physical activity and the barriers faced by our patient population, my experiences working during COVID, and how we're moving forward in the service. I just want to start by saying that in this service at Homerton Hospital, we've had a bariatric physio going back to about 2010. And I think there was a real need by the therapy managers there. They'd seen that there was a need. We were having a population of patients with a higher BMI coming in with comorbidities, and I think we wanted to make sure that they were looked after and well treated. And so I know that there are a lot of services out there that don't actually have a physio in place, but we're seeing more and more services in tier 3 and in tier 4 with physiotherapists and sports therapists as part of that MDT team. I think it's really important. I think that physios are perfectly placed to work with the population of patients because our role is really to identify and maximize patients' potential and ability to move and function. And functional movement is a key part of what it means to be healthy. And we talk to our patients about being healthy, having a healthy diet, mental health, and increasing their physical activity levels. So how do we enable them to do that and manage that in a safe way? Our knowledge of anatomy, physiology, and the psychosocial mechanisms of health and disease aid us to assess and diagnose these patients. And exercise prescription, which is a cornerstone of our role, we're able to offer them the benefits of that and to help manage their long-term conditions. I think of myself as a behavioural change therapist and working with the patient and managing that change. And I think we're very good at spotting ambivalence in our patients, but also to realise when they're ready to make those changes. We can make physical activity recommendations based on their ability, and we know what to look for to help them. And then I think part of that, as well as is our intervention, is to signpost them into places where they can receive the help that they need, depending on what's good for them. We have a great knowledge of MSK presentations, and we see a lot of that in this population, things like osteoarthritis, plantar fasciitis, lower back pain, carpal tunnel. And then there's the range of patients that have persistent pain, rheumatoid arthritis, fibromyalgia, and a lot of these long-term chronic fatigue issues that we're seeing with our patients. We know that physical activity is medically proven to improve these things. And so how do we work with our patients to manage these conditions? The way I work is clinics and ward-based work. I hold one-to-one clinic sessions where I look at taking a really subjective and objective assessment to get a real understanding of the patient presentation. Obviously listening to the patients and helping them and identifying what their needs are, what their concerns are, and what further MDT inputs needed. And not just from the AHPs, but maybe from our physician, and also, just looking at whether they are a candidate for surgery. As I said before, we make onward referrals. Importantly for this group, we look at setting goals based around things that are important to them, their values, and then reviewing those goals and progressing them as we can. The highlight of my job is the exercise classes that I run, and these are physical activity, circuit and education groups that we run for patients, and we do this pre and post-operatively, and then making assessments that I can report back to the MDT on their fitness for surgery, looking at typically things like 6-minute walk test, but also vestibular assessments, balance assessments, and typically in our population falls assessments. I also do some ward working, and I see post-operative patients, and usually to help with them, get them out of hospital after surgery, after bariatric surgery, looking at really helping them with their respiratory concerns and circulation concerns. So trying to minimize the risk of vein thrombosis and chest infections after surgery, and again, promoting physical activity for them. As I said, one of the highlights of my role is the PACE class that we run. We run this for patients preoperatively and postoperatively. I think one of the things that I really enjoy about the group is the support network it brings for the patient. It gives them confidence to be able to move and exercise in a setting that's safe, and where they're working with people who look like themselves, who move like themselves, and have the same situations around physical activity that they experience. And as I've talked about before, referral criteria may be lack of mobility, lack of confidence. It may be specific concerns around MSK presentations and issues that we can work on. There are currently no specific guidelines for exercise prescription for the bariatric community. And so when we talk to them, we tend to follow standard guidelines for adults. And that is typically, 30 minutes a day, 5 days a week, moderate intensity to be able to increase our respiratory rate and our heart rate. And these guidelines are guidelines, but I think they're important and that people can understand what it is that they should be doing and how it can benefit them. We know that in our population, it's not going to be everybody that's going to be able to manage these things. And we're not asking for them to run marathons or to climb Mount Everest, but try and incorporate into their daily lives small changes that they can make that will improve their health. We talk about breaking exercise down into small chunks, 5 to 10 minutes in the morning, in the afternoon, in the evening. And as I say, fitting it into their lives when they're picking up the children from school, when they're walking to the bus stop, walking up and down the stairs as opposed to using the lift. These are the kind of basic information that we give them. We know that physical activity can improve their risk of type 2 diabetes, of high blood pressure, of stroke. We know that exercise plays a big part on insulin resistance and also visceral fat. And we know that the benefits that this can bring. So it's really, really important that we're able to give this kind of information. The evidence tells us that aerobic exercise, resistance exercise, and even HIIT exercise, which is high intensity interval training, can be of benefit to people. But it's how we manage this in our community and how we allow these people to integrate and to manage these situations. Graded exercise is really important with our population, so starting really slowly and building up, and pace management, especially with our patients who have these pain conditions. We have to be careful that we don't exacerbate their symptoms and that they're not out for days on end for that more bust kind of situation. We want to manage that and control that. We talk about walking, cycling, swimming, housework, gardening, any of these situations where they can get some benefits. We know that our population has a number of barriers to physical activity. Fear of physical exertion, if you're being told to exercise but you're short of breath, how does that feel? How does that make you feel? A lack of confidence, lack of motivation, fear of stigmatization and weight bias, and maybe just not understanding what physical activity is and what it involves. people have had bad experiences and have had injury, and this can make them afraid and very resistant. Obviously, and also there are health conditions that feel worse with activity, as we've spoken about, in terms of pain. For some people, it might be lack of time, money, opportunities. And then there's a confusing message: not exercise, do exercise, depending on what your health conditions are. So these barriers, we try to work with people with. We need to be compassionate, we need to be sensitive, but we're trying to help them to improve. And then to try to address some of those barriers. And what are the changes that they might would like to make? How will adherence to exercise increase them and their health? Trying to establish values, which is a lot of ACT-based work at the moment, working with our psychologists, but how we can establish their values and reward their achievement and support them to make a change plan. But as I said earlier, we need to set realistic goals. We know that these guys are not going to be able to go out and do lots, but actually encourage them to do as much as they possibly can. We also try to move away from that model of, if you eat less and you exercise more, then everything's to be okay. We know that doesn't work in this population. It doesn't work for a lot of people anyway. So being very careful of the messages that we're giving people. We understand that obviously there are problems associated with bigger bodies, the strain that's placed on their joints, especially the lower limb joints, because of that excess weight, inflammation that can cause pain, and the greater stress on the respiratory system. We've talked a little bit about how people feel in terms of shortness of breath, so that reduced lung capacity. And then there's things like simply just the base of support and the postural muscles are affected because of the weight and where it is and how that affects them. So doing that kind of postural work and strengthening work. Also, the stress incontinence that a lot of people face because of the pressure on their pelvic floor. All these things that are really difficult for people, and we understand this. And then the basic embarrassment of getting really hot and sweaty, and maybe smelling. Maybe there's noise when the skin moves, the skin rashes. All these different things can cause problems for people in a bigger body. COVID has had a huge effect on our population as well. A lot of them had to shield because they were vulnerable adults. They've become more sedentary. They've been at home, working from home. The physical activity that they might have had just going to work or being at work has been reduced. And we're seeing lots more weight gain, higher numbers of weight gain. And people are more reluctant to engage in activity because of how they feel that they look, and how they feel that they'll be judged. And then we've got long COVID as well. People are experiencing brain fog, fatigue, and then reduced exercise tolerance. So all of these things are combining at the moment to have, in sometimes really negative effects on the patients and the populations that we see. So for myself, during COVID, I was redeployed to work in an IT unit at least twice, and I think I'm at the front of the queue to be redeployed again if anything happened. For me, it was very, very overwhelming, not least thinking about how our patients were managing, but just being in that situation yourself and having that added stress at work and at home and not knowing what was happening. We moved from face-to-face appointments immediately to initially phone calls, which are not very effective in our population. You can't see, touch, feel patients, be able to really give the advice that you need. It's very difficult to talk to people on the phone. And we've gone to video calls. We find that patients are more distracted. Many conversations with people who are still in bed, or who are in the car, or doing other things, and they're not able to concentrate fully. So their learning and our ability to assess has been difficult. And I know this has been the case for everybody in healthcare. Compassion fatigue, and burnout has been a huge part of what we've experienced and how we're feeling, and it's been very difficult. And from the standpoint of our exercise classes, we've got reduced numbers, we've gone online, and that comes with associated risks, and having to do risk assessment and new ways of thinking and trying to manage that situation of somebody who's exercising at home with nobody around them to make sure that everything's okay, and that they may have some comorbidities involved. So these are some of the things that have happened and that we've had to face. I think moving forward, we have understood and we realise that there are some benefits to online working. We have such a large catchment area in the Homerton, and we're seeing people from the whole of the southeast of London, so England, and so we understand that actually, if we are able to create things and resources that people can use, that's actually going to be quite beneficial, and we can hit a wider audience. We are doing more on online classes, and for me, catch up with my increased waiting list, which was decimated when I was redeployed. We're looking at online group sessions where people can actually get information and advice, and we can still help them, but more in a group session. The ones that need more of a one-to-one input can still come in and see us. We're starting a new tier 3 service in City and Hackney, and so that will mean that additional physio cover, and which means we'll be able to do a bit of cross cover working. So some good things to look forward to. I think what I'm really excited about is creating some resources where we can make videos for people with people that look like themselves. So we're looking at recruiting some of the post-op patients and some of the pre-op patients who are in the class to be able to create some resources that they feel that they need. Because I think at the end of the day, we have to listen to our patient population and hear what they're saying and trying to give them what they want. I think that's it for me for now. Thank you for listening. If anybody's got any questions.
Thank you. Thank you, Jen. There is a question.
Sure.
Having a dedicated physio attached to the service is fantastic. It must be inundated. How do you prioritize who you work with?
Okay, so we prioritize, I think, the people with the greatest need, and that need is it kind of comes in terms of referrals from the different AHP, but also from the MDT. So if we know that there's somebody, either their mobility is very poor or maybe cardiovascularly they may be challenged, then we can get those guys in and do some of our assessments, maybe a 6-minute walk test, and further investigations. I think restrictions have meant that there are many causes, many problems such as sarcopenia and these sorts of things. So I'm very much led by the MDT and also the AHPs. That answers your question.
Thank you. There is a question from Dr. Manisha Sharma. I'm not sure she wants to ask the question, or should I?
Yeah, I can ask directly. Yes, thank you so much, Jen. You do a fabulous job, you and your team, for our bariatric surgery patients. Like when I will highlight in one of my cases in the afternoon session. My question was, how are we with the resources, especially after the pandemic? Like some patients who have been immobile for almost 2 years, not getting the surgery. How are we in terms of the resources? Like if we want to give patients with frame, with a seat, how are we in terms of resources?
So thanks, Manisha. You know, all the patients that we see, we do assess their mobility, or I assess their mobility and see what they're doing. If they need things like walking aids, we provide that, whether it's walking sticks, crutches, frames, we can provide that. If I feel that there's more of a sort of a need for an occupational therapist, I will refer them locally for that assessment. Sometimes people are not managing at home, they can't manage their watch and press. There may be a need for carers and so on and so forth. So we will refer them, we'll look at them, we'll assess them, and then we'll refer them on. Hey, in Hackney, the Homerton, we spent a lot of equipment. It's not the same in a lot of boroughs, and I know people in some boroughs have to buy these things themselves, but in Hackney, we're very good at providing people with what they need.
Okay.
Thank
you very much, Jen.
Next speaker.
Hi, everybody. I want to give a very warm welcome back to Dr. Denise Ratcliffe, who you will have heard this morning. So she needs no introduction. She's going to be speaking about the post-operative issues after bariatric surgery. And also, I just want to mention that she's the author of Living with Bariatric Surgery, that many of our patients find a really useful resource, and especially for those who live in the UK, because Denise is a UK psychologist, so very relevant to our audience. So welcome, Denise.
Well, thank you very much for the warm introduction and the opportunity to speak twice at the conference. I'm going to hand over to the tech team because I've pre-recorded my talk, but I'll be here to answer questions at the end. So in this talk, I'm going to focus on some of the psychological issues that people may experience following bariatric surgery. I'm going to start by just briefly giving a bit of a context for understanding these post-op problems. I'm then going to focus on some of the rare but more extreme problems before moving on to think about the psychological difficulties that are almost an expected part of the adjustment process. I then briefly want to touch on post-op psychological support. So as I mentioned this morning, when we're thinking about the type of difficulties that people experience before bariatric surgery, I mentioned that there are much higher rates of these difficulties. In particular, depression, anxiety, and binge eating disorder are the most common, but we also know that things like deliberate self-harm, history of suicide attempts, personality disorders, and abuse and emotional neglect are also higher amongst this population. One of the important things to mention, which I'm sure you're already aware of, is that the past occurrence of mental health problems is the best predictor of experiencing those problems in future. So given that this is a group who have experienced higher than usual rates of mental health difficulties, it's inevitable that some of those people are going to experience difficulties in future. So we've got a group with higher levels of psychological complexity undergoing a complex and challenging procedure, which requires permanent behaviour change and development of new coping skills and all sorts of adjustments. So it's highly likely that some will experience difficulties. It would be more of a surprise if people didn't experience some problems or challenges after surgery. Whilst I'm going to spend most of this talk thinking about the problems that people experience after surgery, I do want to point out that surgery is mainly associated with positive psychological outcomes. And I'm sure you will see this in clinic all the time, that people generally feel more confident, they experience an improvement in their self-esteem, they feel less stigmatized, an improvement in quality of life, they're able to re-engage with things that are meaningful in their life or try new things. And there's a reduction in depression and binge eating. And I'll come back to that in a minute. What I would say, though, is that these improvements tend to correlate with weight loss. So whilst people are losing weight, you tend to notice and people report those psychological improvements. But when weight loss stops or people start to regain, it starts to unravel a little bit. There was a study by Kalachian in 2019, and she followed people up for 7 years after bariatric surgery and found that those people who experienced post-op mood disorders are more likely to experience weight regain as well. So there's a general pattern, I would say, of seeing short-term improvements in psychological difficulties, but these tend to re-emerge over longer-term follow-up. So when you look at those studies that have followed people up for 5, 7 years and so on. So in terms of the issues that cause concern, I've divided these into mental health issues and weight and eating issues. So on the mental health side, I'm going to give you a bit of information about suicide rates, self-harm, destabilization of mental health, and alcohol issues. On the weight side, I'm particularly going to touch on binge eating, sort of loss of control eating, anorexic and bulimic presentations. So thinking about suicide rates, there's fairly consistent research now that shows that rates of suicide actually increase after bariatric surgery. So rates of suicide are 4 times higher in the bariatric population compared to the general population. So 4.1 cases per 10,000 person years in the bariatric population, versus 1 case per 10,000 person years in the general population. So the base rates are still very low, but it's a consistent elevation. And in terms of the timing, it looks as though this tends to be more of a problem around the 2 to 3 years post-op mark. You might think that that's because that's often a time period that's associated with weight loss stopping or some sort of weight regain. But actually the research doesn't really point to that as a factor. So far, the main issues that seem to have emerged are the potential impact of alcohol. So people developing alcohol problems and that having an impact on their mental health, but also recurrence of depression and or undertreated depression due to the reduced bioavailability of medication following surgery. If we think about self-harm, deliberate self-harm rates in the bariatric population are higher than average before surgery anyway, so twice as high before surgery. And there's a slight increase in this after surgery, but again, fairly low base rates. And in this study that was done by Barty in 2015, all of those self-harm events occurred in those with pre-morbid mental health difficulties. So as I mentioned before, past experience of difficulties is associated with future experience of difficulties, so the risk factors are there. So thinking about destabilization of mental health as well. So this can happen. It's an unpredictable event, and in my experience, it tends to happen in people who have a history of fairly significant mental health problems, who may be no longer able to use food to manage emotions. For some people, it may be that they disclose difficulties that they previously hadn't felt able to share with the team before, maybe a medication or an absorption issue, but also the discovery that some problems remain, so bariatric surgery doesn't take away all difficulties. Also, life continues after surgery, and so for some people, they may have experienced lots of stressful life events which have just sent them way off track. Alcohol issues can be an issue, particularly post-bypass, and I think it's really important that the whole of the team is aware of this. So again, some really consistent evidence that's come out over the last few years. So King et al. In 2017 had followed people up for 5 years after having surgery and found that those people having a bypass are at twice the risk of developing alcohol use disorder. And what's really interesting is that this is a risk that keeps on increasing. So although many bariatric services seem to tell people that they shouldn't drink for 6 months or a year after surgery, this study found that the risk of alcohol problems increased year on year up to 7 years following surgery. So by that point, a fifth of people were reporting symptoms of alcohol dependency. So regular alcohol use, recreational drugs and smoking in the previous 6 months prior to having a bypass is associated with problems post-op. But it's important to note that a distal problem of alcohol problems is associated with a good prognosis and shouldn't necessarily be seen as a very significant risk factor. It's also important to be aware that 60% of those people who developed problems after having who developed problems with alcohol after having the bypass, it's a new onset, so they hadn't had any harmful alcohol use at the time of surgery, and 7% reported no harmful alcohol use ever. So it's important to be aware that this can be a new problem for people, and I will always flag this information up to people pre-surgery. So moving on to think a little bit about some of the eating disorders and problems that may occur after surgery. So Mitchell quite rightly reported in 2012 that eating disorders post-op tend to be underreported and misidentified. And patients may not necessarily volunteer or even identify these difficulties post-op. So for me, the onus is on professionals to really be aware and actively assess these difficulties. It's important to do that in order to intervene quickly, because these are problems that can escalate fairly quickly, I would say. And for me, there's two extremes with the disordered eating. So at the one end, we've got almost like the over control, which is associated with restriction and avoidance of food, and then loss of control associated with binge eating and grazing. And I'm just going to touch on these briefly. So as I mentioned earlier, there are quite high levels of binge eating disorder amongst people seeking bariatric surgery. And some people will continue to experience problems afterwards, but the same criteria don't quite apply, because afterwards people can't eat an unusually large amount of food, and that's one of the main criteria for binge eating disorder. So the bit that we're really interested in is the loss of control aspect, and that is defined as giving in to impulses to eat, not being able to stop eating when started, feeling helpless to control food urges, making a decision before eating not to control what you're going to eat, so giving yourself permission, going out of your way to get food that you crave, keeping eating even though you feel you should stop. And that's quite a useful definition, I think, of how binge eating may arise post-op. And as I mentioned, it's often referred to post-op as loss of control eating. And approximately 50% of those who have pre-op binge eating disorder will develop loss of control eating following surgery, but we currently don't have any way of predicting which people are going to continue to have problems. So in terms of the impact of post-op loss of control eating, the decrease in symptoms noted shortly after surgery tends not to persist. So about 50% will have problems at 2 years, and similarly, from 6 months on, the rates start to increase again. Those people have less weight loss at 6 months, a year, and 2 years, but they also have poorer psychosocial outcomes. And this has been a very consistent finding now. So a meta-analysis showed that those with loss of control eating have less weight loss and or more weight regain. There's also an issue of purging following bariatric surgery as well. So a study by Deswain showed that 25% of people vomit regularly post-op, 12% of those with the intention of influencing weight and shape. And it can obviously be difficult to disentangle the side effects of surgery versus purging. But really the question is this a behaviour that's being driven for weight control reasons? Is that the underlying function of it? So there is a rare issue of restrictive or anorexic eating disorders as well. So that was defined by Siegel in 2004 as post-surgical eating avoidance, characterized by greater than expected weight loss, fear of weight regain, obsessive weighing and focus on weight, preoccupation with getting into the BMI below 25 category, lots of restriction and body image disturbance. The risks for this, and this is based on my experience, are post-op complications, problems with texture progression, misinterpretation of excess skin as fat, and then that creating body image disturbance, and lots of fears of returning to the weight that they were before surgery and almost becoming over restrictive as a result of that. It's under-recognised and under-reported. The prevalence is unclear, but it's likely to be higher than we're aware of. Sometimes these people struggling with that, this can go unnoticed because other people may be congratulating them on their weight loss as well. So what are the psychological issues that are an expected part of post-op adjustment? So as I mentioned afterwards, everybody's likely to experience benefits and challenges because surgery has such an impact on so many domains of somebody's life: eating, weight, relationship with food, identity, relationships with others, body image, and so on. So some of the adjustment issues that tend to come up are difficulties updating body image, coping with excess skin, changes in relationships, the loss of food, lack of enjoyment from food, unmet expectations, so the idea that some problems remain, surgery and weight loss hasn't fixed everything, coping with attention and increased visibility. For some people, there's a delayed development, particularly with relationships, I would say. So people who may not have had that opportunity earlier in life because of their weight, and avoiding those situations now have to try and get to grips with dating and sort of starting to engage with relationships when they're in their mid-30s or 40s. Anger at being perceived and treated differently just because of weight loss and so on. So I guess just to conclude, I would say that psychological difficulties are to be expected in light of the vulnerability of this population, the nature of the surgery, the magnitude of the change required, and the adjustments that come alongside that. Generally, surgery leads to lots of improvements, but it can and it does create a different set of psychological challenges. Patients that experience post-op difficulties are at greater risk for poorer weight loss and psychosocial outcomes, and the post-op experience of those is a better predictor than pre-op. And given that those post-op difficulties are more aligned with outcomes, for me, we need to be much more able to respond promptly, and that again raises the issue of whether our services are set up in such a way that we can respond promptly post-op rather than focusing so much on pre-op input. So as I mentioned, post-op psychological monitoring and adequate resources to respond are a really important issue. Thank you very much for your attention, and if anybody has any questions, then feel free to email me as well.
Hi Denise, that was excellent presentation as always, and I have a couple of questions from the audience. So the first one is that given suicide rates increase 2 to 3 years post-surgery, which is when you've mentioned that people are discharged from the specialist services, should patients be having a psychological assessment prior to discharge? And also what I want to add is that we obviously tend to be better at actually mentioning the importance of post-op annual reviews nutrition-wise. Is this something we should be putting in the letter to the GPs about the increased risk of suicide and increased risk of alcohol use?
Yeah, thank you for those questions. I guess for me, there's a bit of an issue, a wider issue in terms of whether we should be discharging people at 2 years from bariatric services anyway. It's never quite made sense because we know consistently that that's the time period when people do tend to struggle more. So I guess on a broader level, for me, I think we should have a much more flexible approach to discharge, so that if people are sort of doing well and they're fine and they're sort of on track, then obviously it makes sense to discharge them, but there's always going to be a subgroup of people who are going to require more specialist input, and realistically I think they need to remain in our service. I think there is something helpful about continuing to assess people and sort of review people during their post-op sort of recovery. I'm not sure that it's that great to do it just before they're planned to be discharged from the service. For me, I think there would be something a bit more helpful about doing that earlier on. So, you know, in the guidelines that we've developed for psychological support pre and post-op, we recommended doing that at 9 months. And I think that that should be offered to people on a fairly regular basis so that we can intervene if needed fairly early on in the process. I think with regard to the discharge letter, I think that's a really good point, actually, and I think it would be very useful for health professionals and GPs and other team members to be aware of the issues with alcohol and suicide rates longer term. So yeah, I think that is something to bear in mind.
Yeah, that's great. And then just time for one more question, and this is from Shelley, and she wants to know your opinion on whether diet low in food items that help secrete serotonin can be a risk factor for post-op depression or suicidal risk. That's
a good question. I think that they could be a factor in there, but I wouldn't suggest that they're the only factor in there, to be honest. So I think that past experience of depression is likely to be a much stronger predictor. But amongst that, I guess there is something about not just the serotonin producing foods, but also something about people's emotional relationship with food, and that having to change after surgery, and perhaps the loss and the different relationships that brings up. So yeah, I think there's lots of different factors involved in that process.
Okay. Well, thanks once again for an excellent presentation, and I'll now hand over to Tamara, who's going to introduce the next speaker.
Thank you.
Thank you, Mary. It's my privilege to introduce our next speaker, who really needs very little introduction because she's well known in the bariatric world, as well as she gave an excellent talk yesterday. So today she will be speaking on why keeping weight as a psychological issue is a good thing. We welcome Jane Ogden. Thank you.
Hi, thank you very much. I hope you can see me. My camera's slightly playing up, so I can mostly just see my left ear, but I'm assuming that I'm here, and I'll share my screen. Well, thank you very much for asking me again to give 2 talks at this conference. And I feel very much that I'm kind of preaching to the converted, really, after having heard some of the talks yesterday, and also just listened to Denise's talk and also Jen's talk as well about being a physiotherapist, which were clearly, riddled with psychology. So I don't really feel like my talk is particularly necessary, but hopefully there's some people out there that don't realise that weight is a psychological issue, and so may well benefit from some of the things I've got to say. So I suppose the background to my talk is sort of a concern, which I suppose I also voiced yesterday a little bit as well, is about the emphasis increasingly on biology, on surgery, on medication, when we're thinking about obesity management and obesity onset. And clearly, obviously, within the conference, it's a kind of broad spectrum of interests. But again, there's an interest particularly on the kind of biology behind weight and weight management. And it kind of got me to think about where the psychology has gone, perhaps, in some of that kind of broader thinking. And then I started to think, well, maybe actually the definitions that we think about in terms of psychology are just very kind of narrow, and that we should be thinking about psychology in a much kind of broader range in terms of how we understand patients and what patients go through when they come into the bariatric service world. So thinking about the kind of the broadest role of psychology that's possible, I suppose, in terms of weight onset, but also weight management, and just thinking about how psychology is irrelevant to all those different components of developing a weight problem in the first place, and then also having that weight being managed. And I suppose just to kind of to focus on the broad role that psychology plays in understanding weight, which I do feel that we've just kind of had perfectly, but anyway, I'm going to just kind of add to that. So the 3 components which seem to get a lot of emphasis these days are biology, and particularly in terms of the role of the hypothalamus in the brain as being seen as the kind of appetite regulator. And we hear about how that's driving food choices, it's driving appetite regulation and food intake and overeating and undereating. And we've also heard about how that's sort of separate from areas of consciousness, and that the foods that we eat are driven very much biologically from that kind of central mechanism. And then clearly, it's very clear that bariatric surgery is by far the most effective form of intervention for weight loss and weight loss management, and it's more effective than behavioural interventions. And the emphasis is on increased access and how we can make it more available for people, and also how we can provide more support for people, as Denise has just been talking about, post-surgery as well. But it is clearly, surgical interventions are the most effective. And then also over the last year, particularly, we've been hearing a lot about the benefits of medication, whether it's through orlistat, which has been around for a while now, but also through semaglutide, and seeing the evidence that's come out about that. And they both show impressive weight loss, and again, far better than behavioural interventions on their own. So within all that kind of framework, obviously the emphasis is moving away from behavioural interventions and the psychology of weight. And that's why I started to think what's happened to psychology, and where is psychology out there? So looking at the kind of the talks which are often given and the frameworks which are often used, you can see there's a emphasis on Stunkard's work on twin studies, which was done in the 1980s, and that's still very much cited. We have a lot of emphasis on the physiological mechanisms or the metabolic mechanisms, on the hypothalamus, on endocrinal factors or genetic factors. And you can see these different slides very much are emphasizing the kind of biology behind weight. And then we have biology integrated with environmental factors. And so the emphasis is on what the body is doing in the context of that environment out there. But if you look at the ways in which it's being talked about, a lot of these things I would think were psychology, but are actually not being called psychology. So there's evidence there about sedentary lifestyles, food intake, eating behaviour, physical activity, around behaviour in general, and then looking at the ways in which people are having high-fat diets because those are being presented to us by our environment. So the psychology is there, but somehow it's not being called psychology. And I think part of the problem is that we have a very narrow understanding of what psychology is interested in and what we're thinking about when we're thinking about the psychological issues around weight and weight management. So as Denise has just been clearly talking about, there's a very strong case for the role of psychological support for people pre and post surgery. And that focuses on issues like depression, anxiety. We've heard a lot about suicidality, but binge eating and eating disorders, and then feelings of guilt and blame and notions of willpower. So that's seen as being where psychology sits. And that's why there's been a push to having psychologists involved in patient care, both before and after having their operation. But psychology, for me, I'm a health psychologist rather than a clinical psychologist, is just huge. And it encompasses so much more of the patient experience. And it's around their beliefs, their emotions, their perceptions of risk, their decision-making processes, their perceptions of hunger, perceptions of fullness, their eating behaviour, their exercise behaviour, their self-esteem, their body image, problems of addiction that we've also heard a bit about today, their learning and where that comes from their childhoods and within their families. And Tony talked about that yesterday, which was fantastic, learning about kind of family environments, but looking at bigger issues like culture, the role of relationships and the impact of choice. So if you take that very, very broad view of what psychology is, then it feels like psychology is key to all aspects of weight and weight management, even if we're taking a biological or a surgical perspective. So in terms of the biology of food intake, models would say that there's a hypothalamus which is driving what we eat. But we know that research will show that hunger is a perception rather than a sensation, which is modified through distraction, through focus, through the meaning of food, and that the calories going into the body don't then necessarily determine how full someone will feel. And it very much is more determined by whether they're thinking about the food that's going into their bodies or how they frame the food that's going into their bodies. We know that emotions can drive what people eat, and that emotional eating can happen when people overeat when they're feeling upset. And sometimes they will undereat when they're feeling upset. And we know that people make decisions around what foods to have, and that those choices are being made at the point of making the decisions. We also know that relationships are key to how much people eat and the decisions they make about the foods that they have. We've done some really interesting work looking at dynamics within couples and how one partner may well use food as a sign of love or as a way of managing that relationship, or even just because they don't want food to be in the house. So there can be kind of dynamics going on within relationships. And then bigger problems like the role of culture or the role of body image and self-esteem. And then we've got issues of risk and risk perception. Do people perceive diabetes to be a problem, or do they perceive obesity to be a problem, and to what extent? And then self-esteem and learning. So psychology surrounds all of the biological moderators of eating behaviour. And then on top of that, if you think about the surgery, then again, you've got a whole kind of plethora of psychology around the role of bariatric surgery. You've got patients' choice in the beginning to have surgery, their decision-making processes, how they weigh up the pros and cons, or whether they want to make that kind of long life change for themselves into the future or not. Issues of risk around the surgery itself, but also issues of risk about the consequences of the surgery, but risk again about carrying excess weight and whether they see that as being something that they want to avoid. Role of the culture, bariatric surgery is clearly more the norm in some cultures than others, or is less stigmatized in some cultures than others. Again, issues of relationships driving people to have bariatric surgery or not. And then just the process of attendance or adherence. So people have to go to the clinic and they have to adhere to the recommendations after bariatric surgery. And again, like we've been hearing, people have to, well, we would like people to turn up 1 year, ideally, and ideally for longer after surgery. But that choice to attend, those processes of adherence are also psychological. Do you feel that the surgery is done and dusted, therefore you don't want to go back, or do you still want to come for support? And then issues around exercise and eating behaviour after having had surgery. So whilst surgery is clearly a kind of medical, a surgical solution, it requires psychology for the benefits to last into the longer term. And then exactly the same could be seen around medication. So again, whilst medication is a medical intervention for weight problems, the whole process of taking medication, adhering to medication, choosing to take medication, and then again, behaviour change post-medication is embedded within a psychological framework. So we know that patients choose to take their medication and that they might forget because of issues of distraction, or they might not want to take it because they don't want to have the consequences, or they have to attend the clinic to get their medication. And that again can be disrupted by the cost-benefit analysis of not wanting to take time out of work, or not being able to get there, not being able to pay to get there, not having caring responsibilities, which mean they can't get there. So attending to get your medication is again a psychological process. And then even if you take medication for weight management, there still needs to be behaviour change following that, which again is a psychological process. So I suppose my sort of take is that we do think about psychology in the context of weight, but in a very kind of broad, very narrow kind of sense in terms of psychological issues before and afterwards, focusing on binge eating or depression or anxiety, and again, thinking about previous talk on suicide, but that the whole of weight, whether it's the way in which we eat to start off with, or whether we're being managed surgically or medically, is also embedded with all sorts of psychological issues. And that ultimately, these are human beings, and their beliefs, their expectations, their emotions, their learning, their childhood, and all of the things that people feel are then being impacted upon their choices to have these interventions, and then how they actually respond to them. So thank you.
Thank you very much for that excellent presentation, Jane. I think we can all agree that psychology is such a vital part of weight loss of bariatrics, and where we've got the privilege to have 2 full-time psychologists, and we still need more, and I know that there are centers probably just that are so under-resourced with psychology input. Are there any questions coming up?
The question.
Oh, sorry. Yeah, are there any questions coming up for Jane?
I think there is from Lindsay. We come across patients post-operatively.
Yeah, I think that was for Denise, though. I think that was for the previous talk, and Denise
came late.
Addressed it. Yeah.
Sorry, no new questions.
No new questions. Okay. Well, thank you again for that excellent talk.
You're very welcome. Thank you.
Yes. I will hand over to, I'm not sure who's the next chair, but Adam?
Yes, next presentation, Professor Yitka Graham, Professor of Health Services Research at Sunderland University, visiting professor of Anahuac in Mexico, lifetime member of Mexican College of Surgery of Obesity and Metabolic Diseases, National Research Lead for British Obesity and Metabolic Surgery Society, and head of Helen MacArthur Nursing and Care Research Institute. Presentations about long-term community follow-up from patient and professional perspective.
Great. Thank you very much. My presentation is pre-recorded, so I think that's going to come on, and then we can take questions afterwards.
Yes.
Good morning. I'm Dr. Graham from the University of the LIBSS AHP program. What I'd like to speak to you about today is a long-term follow-up of bariatric surgical patients in the community, patients and professionals' perspectives. I'm going to present the preliminary findings of a study that I've just completed, and I also want to speak about the process of carrying out research in collaboration with our community colleagues. So the background to this study is that patients are discharged from hospital into the community for 2 years of follow-up after surgery, following 2 years of follow-up after surgery, pardon me. NICE guidance for annual monitoring is ambiguous in terms of the role of general practice. Published recommendations are not well known in general practice, and within our bariatric surgery community, I'm aware of colleagues who have published recommendations and suggestions for the follow-up in the community. However, these are not well known by our general practice colleagues. There's a paucity of research on what is needed and wanted and resources available in the community from the perspectives of both general practice and of patients. There has been to date little collaborative research with the community about bariatric surgery, but co-design means both parties have ownership and can actively participate in research from design to dissemination, which is really important in terms of robust study design and participation. So the aims of my presentation are to give an overview of the rationale for the study and its design, present the emergent findings, and just give reflections on the process and some of the lessons learned, which I hope would be quite positive, encourage some of you who are thinking about doing research with our community colleagues to really consider it and take it forward. So the initial engagement work for this study, we identified a need to understand a little bit more about what is actually going on in the community following surgery. The idea for the study was discussed with a representative sample of bariatric patients. The suggestions informed the final protocol. What was really evident is they didn't want to take part in focus groups. They didn't feel a survey, nor did I feel a survey would give me that rich data I was after, but they were in agreement that individual semi-structured interviews were the best way to collect the data and that they personally would feel comfortable taking part in. The CCG had commissioned the research pre-pandemic, but owing to the impact of the pandemic, we did decide to put the study on hold for a year. And I would say it probably was the best decision that we made. What we found out, and again, looking back, that there was a lot of things with respect to support and perspectives that were influenced by the pandemic. And had the study been completed prior to the pandemic, I would argue that many of the findings might not be applicable in the current day. So again, it's probably one of the few times I was actually quite happy that a study was put on hold. When we agreed collectively between the CCG and myself and the patients that the time was right, the study was built into the agenda of the Community Service Development Group. And I think that was really important, looking at the beneficiaries of the research from the healthcare professional side. It gave me a place to discuss the study design, gain access to a representative sample similar to the patients of healthcare professionals who I would recruit to take part in the study. And again, it provided a lot of support for the delivery of that study. You can imagine, as any of you who've done research during the pandemic, it is fraught with difficulties. And again, in general practice, I knew there was pressures in general practice, but in terms of the context of me needing to deliver a study to time and target, it was really important for me to understand those wider difficulties, so that sort of I could still carry out the research, I could still recruit, but not cause any healthcare professionals undue stress or put any pressure on them at a time when, as we know, a lot of people are struggling. So I think that support was really, really important and contributed to the success, and also my understanding of undertaking research in the community in partnership with the clinical commissioning group. The study was adopted onto the NHR portfolio of research, so the CCG had the benefit of the accruals to the study. CCGs are mandated to use research to inform evidence to make commissioning decisions, and also are mandated to be research active. So again, this was something that took a couple of weeks to sort out, but again, the benefits to them, outweighed, a couple of weeks delay to the setting up of the study. And again, really important to consider when you are doing research, in the community with general practice. So the methods we used, the patient participants were recruited from Bariatric Surgical Clinic list in an NHS hospital in the northeast of England. The time frame was anywhere from 7 months to 8 years. We wanted 2 years and onwards when they were in the community. Through a recruitment error, we did get a patient who was 7 months out, so was still under the care. But this particular patient had contact with the GP and the community, so we decided to include that data within the collected data. It did provide some very interesting insights. So healthcare professionals were recruited through a clinical commissioning group using snowball and purposive sample. The data was collected through video and telephone interviews between June and October 2021. The data was transcribed verbatim and analysed using a thematic analytic framework, and it was informed by a social constructivist theoretical lens. This lens asserts that reality is shaped through interactions with others, influenced by life experiences, social norms and values. And I would think in terms of being a patient, a person living with obesity, a patient having undergone bariatric surgery, adjusting to life after surgery, in terms of the role of the various healthcare professionals who took part in the study, having this perspective really helped to understand the perceptions of the roles of the patients and professionals, and we felt it really has illuminated the findings. So in terms of the results, we had 30 participants who took part in the study, 14 patients and 16 healthcare professionals. We had slightly more healthcare professionals because we recruited a variety of healthcare professionals, and we need to ensure we had enough of a group in which able to make findings and compare the data within those individual healthcare professions. So the patient participant demographics, we had 11 female and 3 male, which again is quite reflective of the patients that come through our clinic. The mean age was 51 years, and that's anywhere between 30 and 70 years old. The mean time since surgery was 3.9 years, and that varied between 7 months to 8 years. All participants stated ethnicity as white, and we had 13 Roux-en-Y gastric bypass, 1 OAGB, and these were all primary procedures. There was no revisional procedures. In terms of the professional participants, we had 11 female and 5 male. We had 5 general practitioners, 4 were general practitioners, 1 had a commissioning role as well. We had 4 practice nurses, 7 pharmacists, 6 were involved in primary care network, and 1 was a manager. And then the ethnicity, we had 9 white, 3 Asian, and 2 Black participants taking part in the research. So if we look at the emergent themes from the patient perspective, and again, we're still doing the final data analysis with this study, what is coming out is that they need a more formal, longer support mechanism. There's issues of compliance, long-term after bariatric surgery. The majority of the patients stated about worrying about slipping back into old habits or acknowledging they've slipped back into old habits. And more psychological support was consistently demonstrated as being needed. Now, this wasn't for a particular diagnosed healthcare condition. This was about general support, very much in terms of and they reflected very much on the psychological input that was provided as part of surgery, like getting them used to dealing with life after bariatric surgery, looking at that. And they really felt that was missing from the post-surgical support. And they said, what we do is we actually would like some formal psychological support built into this. There was issues with weight gain and how to deal with weight gain. And again, that was quite situated. A lot of the weight gain had happened during the pandemic. There was weight gain that occurred prior to the pandemic, but it appeared to be a real issue in the current context. But there was just wider psychosocial issues pertaining to the pandemic that patients reported that they wanted further support with. In terms of the professionals, many of them stated they were unsure what is needed to support patients. They referred to the NICE guidelines as being very ambiguous, not providing sort of any real meat in which to develop a framework. They openly admitted lack of understanding, and this is across the, the pharmacists, the GPs, the practice nurses, and the managers, a lack of understanding about bariatric procedures. They all said there was no formal learning within CPD or curriculum about the mechanisms of bariatric surgery or patient support. And the little knowledge that was there was basically self-taught. The communication from the bariatric unit could be a bit unclear and ambiguous. And I think that's probably related to the lack of understanding about the bariatric procedures, but there was in forms of like the administration involved. That was a bit, I think on both sides, really needs to be tightened up. They did report, and again, patients reported this as well, that the GPs felt that the patients came in and sometimes they knew a lot more about surgical procedures than the professionals. And again, it was widely reported about the medication issues as well. Pre-surgically, we have a consultation with a bariatric pharmacist. So the patients have a certain level of knowledge. And again, this doesn't seem to be translated across into general practice. So they said they sometimes felt a bit uncomfortable where they felt that the patients were sort of telling them what they needed rather than, the healthcare professional being able to provide that information. It wasn't rooted in any ego or anything. It was just a genuine concern that they felt a bit concerned that patients knew more than they did, and they felt obliged to have that knowledge, which they didn't have, and that could make them at times feel quite uncomfortable. So in terms of reflecting on the process overall with this study, I think one of the successes of it and the buy-in was that it was co-designed with commissioners, general practice, and patients. I found the patients, as always with any patient research I do, I really find patients are really keen to participate in research. And again, the majority of my research is qualitative research, and patients seem to really buy into the methodology and understand it's really about illuminating their voices and their experiences. I would say patients were far more straightforward in terms of recruitment. Again, we were able to recruit 13 participants for post 2 years post-surgery. And again, that really illuminated that longer term experience in the community, which we know that is sort of sadly lacking in the UK. The healthcare professionals were difficult to recruit. I say they were difficult, not impossible, compared with the patients. I felt at times I was quite spoiled with the patients, but I think we need to take into context the time pressures of general practice at the moment. I did pick up with some, but not all healthcare professionals, there was a bit of an indifference towards bariatric surgery, and there was other competing priorities, and for some that it wasn't a priority for them. But I think in order to be authentic, I needed to ensure we had a good cross-section of attitudes towards bariatric surgery in the healthcare professional cohort. The participants, also the ones who took part, also sent study information to colleagues to try and address this. And one of the things I did say, I said, please don't send it to all your mates who think bariatric surgery is great. If you've got a colleague who is a bit resistant to bariatric surgery, actually, I want to speak to him or her. So I am quite confident that we did get a good cross range of attitudes towards bariatric surgery, which I think is really important when making recommendations for a follow-up service. The Pcm Pharmacist, so these are practice-based pharmacists, and again, where we are, it's sort of a new and emergent role. And the practice nurses were really enthusiastic about the topic of bariatric surgery, despite not knowing very much. And also in terms, they were quite keen to become more involved in the long-term follow-up and support of bariatric surgery, but acknowledged they needed to know a lot more than they did. But, they felt it was quite an interesting group of patients and felt within their individual professions that they had a lot to offer in terms of support. The GPs had a variety of attitudes towards bariatric surgery. And again, to me, that's the real world. Not everybody, as we know, not everybody likes it. So I think had I recruited people who were quite positive towards bariatric surgery, that wouldn't have been really an authentic study. So again, it was really interesting because I think some of the things upon reflection is, you know, how do we address some of that reticence towards bariatric surgery, you know, as a group of bariatric surgical professionals. The involvement of the CCG, as I said before, was crucial to the recruitment and data collection. I attended the steering group meetings for community service planning and regularly presented on the study. And I would say in terms of carrying out collaborative research, having the involvement of the CCG is absolutely brilliant. The only drawback is as of April the 1st next year, we no longer have CCGs and ICSs come in. So watch that space. I fully intend to continue with community research, but again, what that new infrastructure will look like, you know, we all, you know, that's yet to come. So the current status, we're on the final stage of analysis and engagement with the steering group and patient representatives. We'll be writing up a formal report for the CCG. We'll be we'll submit the findings for publication, working with the CCG and again with this group, again, which will go into the ICS about putting these recommendations into practice. And I think we very, very much need to address the training issues with practice nurses in terms of a study day and Pcm pharmacists in 2022. So we're currently looking at what the best mechanisms of developing that training is, and again, how we would get that information to GPs. And what was stated is the GPs would like training, but they've got no time at the moment, which is totally understandable. So conclusions, more research is needed in collaboration with the community and with patients. General practice environment is very challenging, but I have to say I found it really rewarding, and I've established relationships. And I think there was a lot of trust and mutual respect that developed and was established that I know will continue following this study. The pandemic has impacted on patient journeys. Further, more formal long-term support is needed, and psychological support needs embedding in follow-up. Overall, healthcare professionals in the community's knowledge levels of bariatric surgery is low, and there's opportunities for all healthcare professionals to support in the community, to support patients in the community. And I would say that brilliant MDT approach that we have in the hospital needs to be replicated in the community. So thank you very much for your time, and really quite happy to take any questions you might have. Thank you.
Thank you, Professor Graham. There is one question from Mary O'Kane. NICE QS 127 and long-term follow-up guidelines highlighted the need for commissioning long-term annual review and for shared care services to be commissioned. Also, importance of the education of HCP. It's not happened. What can we do to make this happen?
Yeah, Mary, thank you very much for that. I would say, without blowing my own horns about the study, I think this study, you know, once the final report is written up and presented, I think we need the evidence to show the effect of the commissioning not happening is impacting on healthcare professionals and the provision of patient care. So I really hope this study is the start or can contribute to that conversation. I would say, I think we're sort of, it's very difficult at the moment to sort of push anything forward, as we all know, in the current environment with competing priorities. But I would say, you know, the people in this group and, you know, listening to it, I think there's quite a few of us who aren't shy in coming forward. I think we need to be doing our policy advocacy work that we've been doing so well, and just continuing to push it. So I know it's not happened. I think the reasons for it are multifactorial, but I think we can't lose sight of it, and that, you know, the procedure is only the start of that journey, and the long-term follow-up of care is something that we need to push for as bariatric surgical professionals.
Thank you. I got a question from myself. But GP practice indifference that you notice in your research, is it based on a kind of ethnic origin or religious beliefs, or is just lack of communication, information, or training?
Yeah, no, it's interesting you said that. I didn't pick up anything, from a cultural perspective, because we had an ethnically diverse sample group. I don't think it was rooted in that. I think, and there was just, and again, it's almost, I need to almost do a separate study to pick up on that. I think it's probably rooted in that stigma of obesity. I think it's that perception that weight is something that person with the weight problem has to sort it out themselves, and it's not something they should be coming, to a healthcare professional with. I think it's rooted more in that, and again, what we're challenging and working with every day, it's the stigma of the actual problem itself that is causing the indifference, rather than any sort of attitudes on a personal level. If that makes sense. Thank you for that.
Thank you. Another question: do you think some kind of post-bariatric surgery resource pack for GP practice nurses would be useful? This could include specific guidance and evidence around bariatric surgery and post-operation care.
Yes, absolutely. And that is something sort of that we did discuss. I think the most important thing is the format that would come in. If we sent them sort of written information, I think it would just disappear into a pile of paper on desks. And I think because everything is computerized, I think the idea was, if, when they had a bariatric patient with them, if they could sort of push a button and the information would come up on the system and it's easily accessible and they don't have to go looking for it and it's right there in front of them and they can refer to it. I think it's the format in which they can access it that is the need, but very much so that is very important to have that.
Thank you. I know that we have a kind of post-discharge information to GP that Dr. Sharma prepared in our team, but would not be that something established and released on a BOMS level, like national?
Absolutely. I think one of the things is, I think just to be fair, and I think when we're looking at it, I think the community, if we think of our day-to-day roles, we are in the hospitals, we're in the clinics, and, after that 2 years, that our patients are discharged back. But I think we always want to know what's happened. And I think in our minds, in our hearts, the care doesn't stop in the hospital. And I think there is something about developing resources, because we are the ones with that specialist knowledge, and our GP colleagues, they've got, unended amount of healthcare things. So I think anything we can do to build that relationship but build it that we're there to support them, not tell them what to do. And one of the things that they did say, and it's not bariatric surgery, but a lot of times when an intervention takes place in a hospital, the letter that comes into general practice is, you have to do this, you have to do this, you have to do this. It doesn't say, what do you need? And a lot of times the resource that's needed isn't always available in general practice. So I think there's a wider conversation. And I think honestly, in terms of bariatric professionals, I think we could lead on this, because I think, we have that multidisciplinary approach, and it maybe isn't always the GP that needs to provide that support. The nurses and the role of the pharmacist, like many of you who've seen some work I've done before, I'm very passionate about increasing the role of the pharmacist in post-bariatric surgical care. They're an underutilized workforce that has a lot to offer. And I think just collectively to find some sort of mechanism where we can work together with our community colleagues to develop this, and like Manisha's guidelines, they should be, if we could share that learning nationally, we need to clone Manisha and have one of her in every area of the country. That would solve the problem. But no, thank you. And I agree entirely.
Thank you. It's similar.
If I can just say a little thing, Yutka, you are absolutely right. Like what you are saying, getting other specialists, pharmacists and other people involved in the care will change a lot, because they have so much of the clinical knowledge behind drugs and everything that has changed after the surgery. That will be a major impact. And at one point of time, like you might remember, Mary O'Kane and you and I, we were discussing about even having a wristband. Bariatric surgery is critical. Patients should be given a wristband where the clinician, if they reach unconscious to A&E, somebody should know that they had a bariatric surgery, and the management will be different. Thank you.
Absolutely. No, thank you for that.
Thank you, Professor Graham. No more questions. Thank you again.
Thank you, my
Thank
pleasure.
you very much, Itka. Thank you, Adam. I'm introducing a person who doesn't need any introduction. So Tony Jenkins, who is a nurse since 1984, and she had a bariatric surgery herself in 2000, which inspired her to help others. And that's why she did training with her own surgeon in Lyon. And then she further trained as a CNS and working as a consultant in obesity surgery. She's a frequent participant in LBC radio. And more recently, she's working with Novo Nordisk training, and she's training clinicians to prescribe GLP-1s. Over to you, Tony. Thank you very much.
Thank you very much, Manisha. My presentation is going to be the pre-recorded one, so I'll just wait for the technical people to put that on, and then I can take questions if appropriate at the end. Hello, my name's Tony Jenkins. I'm a bariatric and obesity nurse specialist, and I've been working in the field for about the last 21 years. One of the things that recurrent in my clinical practice is that of the patient requesting revision surgery, and I think it's something that most of us will experience sometime during our careers, and I thought it might be interesting to look at some of the reasons why patients might request revision and why revision might be appropriate. So what is revision? Well, revision is any primary procedure requiring adjustment or adaptation. It could be as simple as resiting of a gastric band port. It could be reversal of a primary procedure, so removing a band. Planned second stage, for example, duodenal switch after a sleeve gastrectomy. It could be removal or repositioning of a gastric band, or it could be surgery for symptom relief, for example, gastroesophageal reflux disease, or it could be a secondary procedure. They've had a band in the past, they didn't get on with it, they've had it removed, they want to have something else. So what are the clinical indications for revision? Well, the most obvious ones for us as clinicians will be the patient's symptoms. So dysphagia, gastroesophageal reflux disease, pain, internal hernia, malnutrition that can't be managed conservatively, a persistent leak after, for example, sleeve gastrectomy, or non-resolution or worsening of comorbidities despite weight loss, or the patient's weight or BMI. So, when the patient requests revision, why do they usually request revision? Well, the commonest reason by far is weight regain, or they're dissatisfied with the degree of weight loss. It may be symptom related, for example, GORD, dysphagia or pain. It may be the symptoms of malnutrition or malabsorption. It may be diarrhea and or steatorrhea, or it could be something like a recurrent anal fissure. And a lot of these are problems that really ruin people's quality of life and need some action taking, really. So weight plateau and weight regain, what do we do about it? Well, without question, the commonest way of dealing with this is that of managing the patient's expectations. And I think it's really, really important that this starts prior to them having the original procedure. It's really important. They have to understand that weight plateau is normal. Most operations will have an estimated weight loss, but how we present it to patients is important. If you say to a patient, for example, before a band, you might lose 50% of your excess weight, they will often hear in their minds, I'll halve my weight. So it's quite important to say 50% of your excess weight, so that's half of what you need to lose. In your case, that would mean you might lose X number of stone and get down to X number of stone. So it's much more meaningful to them. In their mind's eye, regardless of the statistic, most women think they're going to be in a bikini on the beach, and most men think they're going to have a 28-inch waist in jeans. And the reality for most patients is that's not going to be the case, but we need to get this across with constant reinforcement. Have they managed to change their eating habits? If they've not managed to live with their operation, it's quite possible they won't be able to make the changes second time round. And that's not always because they can't be bothered. It may be their lifestyle just doesn't work. If they're a rep on the road all the time, or they're a teacher and they don't get time for breaks, those sort of things really have to be considered. Are they eating until they feel full? Are they looking for satiety? And that can be really important, because particularly with a sleeve gastrectomy, if you want to feel full, at about 18 months, you're not going to feel full anymore, because that band is so elastic that you'll be able to eat pretty much what you want as long as you're careful and you pace yourself. And that needs to come across carefully. Dietary textures, are they living off of fruit juices, smoothies and mincemeat? And psychology, have they got their head around weight loss here? So weight plateau and regain, an important thing to consider, is there NHS funding or otherwise? And that often isn't the case in the NHS. If it's simply for weight plateau or regain, it's highly unlikely to be funded unless they need to lose weight for a particular procedure. The time since the primary surgery, if it was only 6 months ago, there really is no value in jumping in at the moment. You need to give it a chance to work and to be able to make the required changes. Some people are just slow burners. It takes them a while to get their head around an operation, and it may take 6 months before they really manage to work with it. So it's very easy to jump in. You shouldn't really do that. And have they considered, if appropriate, one of the GLP-1 RAs, such as liraglutide or semaglutide? And certainly in the March, there was some very interesting research published in the New England Journal of Medicine about the use of semaglutide, particularly with gastric bypass. And some of those patients, it made an enormous difference to their weight. And I've certainly seen patients 18 months, 2 years after a gastric bypass, have had semaglutide or liraglutide and have said, it's amazing, I feel like I've had my operation all over again. So there are non-surgical options out there. For symptoms like GORD, dysphagia and pain, what is their current weight and BMI? Because that has to be considered as to what you can effectively offer for them. What previous treatment have they had with, for example, H2 agonists or PPIs? It may well be changing to a different PPI can help. Jumping in for surgery isn't always going to help. We also need to look at their dietary habits. And are they suitable for links, and is it available? That may be an option for them. So symptoms of malnutrition and malabsorption, well, we clearly need to look at their A, D, E and K vitamins, and that would lead us to consider things like osteoporosis, for example. B vitaminosis, B12 vitaminosis. There are ways of correcting these, but they take time and they need a lot of motivation, and that could be very expensive as well. Diarrhea and steatorrhea, we need to replace the A, D, E and K vitamins because they're not hanging on to them if they're constantly going to the toilet. If we're giving them zinc, clearly we need to be mindful to replace the copper as well. They still have to think about their diet, however boring it is. It might be appropriate on occasions to consider cholestyramine or creon, but as soon as the patient gains weight, they will often choose to have those symptoms back again rather than have the weight gain, and that's something to be mindful of. And on a few occasions, a one-off or second dose of Pabrinex can make a difference to giving patients the energy to continue, so to speak. So recurrent anal fissure, thoroughly miserable and really ruins their quality of life. So we need to treat the steatorrhea, which may mean dietary habits yet again. Topical GTN is available, but it often gives them a very profound headache. Diltiazem is far better tolerated, but a lot of GPs don't want to prescribe it. But it's certainly worth considering, and that can make patients it makes their life a lot better if you can treat it. So really, what are our considerations here? Well, are they clinically suitable for revision? And a surgeon once said to me, you should never offer an operation to a patient in the private sector that you wouldn't ethically offer in the NHS. And I think that's an important thing to hold on to sometimes. If it's simply a matter of funds, that's a different thing. But if it's to do with the fact that you don't actually think it's right, you still shouldn't do it in the NHS just because they have the means to pay. Is the operation funded via the NHS or do they have private funds? If they're a Freemason, there is a Freemasonry fund that can often pay for these surgeries. Do they understand the increased surgical risks and the fact that revision surgeries are not often as effective as the primary? Do they accept the post-op issues? They may be replacing one set of symptoms for another. Can they fund suitable diet and supplements? It can be as much as £40 a month for vitamins, particularly if the CCGs won't fund them. There are no guarantees of outcomes. There should be a psychological assessment and ongoing support, even if it's just talking therapies locally. And I don't think this decision should be made just with one clinician and a patient. I think the MDT should discuss it very carefully before putting knife to skin on this patient. Thank you very much.
Thank you very much, Tony. Excellent talk. As always, thought-provoking. And yes, the things that we are seeing currently, especially after the pandemic, which has even surged the influx of patients going abroad and getting revisions done outside and coming back with complications. I'm just looking for any questions here. Otherwise, I have a question. Right. Tony, you mentioned about funding for the drugs. You are working on a national level and being a regular participant on major discussions in LBC radio. Bariatric surgery is a lifelong condition. It's a chronic condition. And the medications are quite expensive. We see all the time in our practice that our GPs, general physicians, are not happy to prescribe vitamin and minerals. Do you think there is a possibility or any contemplation about considering these vitamin and minerals as mandatory medications, because these are lifelong medications, and if they can be, these patients can be considered as, you know, hypothyroid diabetic patients where they get it free of cost? Because otherwise the burden on NHS when these patients come back with complications, especially malabsorptive surgeries, can be quite serious and life-threatening.
Well, that would be the ideal. I think the difficulty is that there are several other conditions that would also qualify. So if we looked at things like sickle cell anemia, for example, they don't qualify for free prescriptions. And it seems to me that the only people that qualify for free prescriptions are those where you're replacing something that they should naturally make themselves, or obviously post-chemo. I think it would probably make more sense, rather than having an across the board, like everybody diagnosed with diabetes gets all their prescriptions for the rest of their life free. It would make much more sense if the free part was affiliated with the drug rather than the individual. And then if you needed that certain medication, it didn't warrant a payment. And then the people that needed these drugs for life would get them and not have to worry. I mean, I would normally recommend to patients that they buy a season ticket. So you can buy it either quarterly or annually, and I think it works out about 120, 130 pounds. And for most people, certainly having a malabsorptive procedure, they'd get their money back within about 3 months. But it's quite a lot of money that people don't have. But it would make much more sense if certain medications, for example, high doses of certain vitamins, these are not the kind of things you buy in Holland and Barrett. You're clearly only having them if you've got a pathology. And I think that once a clinician's prescribed it, I think they should be funded on the NHS, definitely.
Thank you. Thank you very much, Tony. Thanks a lot for beautiful presentation. And I think I am the next speaker, am I? Right, so I will.
No, Manisha, next speaker is Jessica Book.
Oh, I'm so sorry. So sorry. Yes.
So it's my pleasure to introduce Jessica Mock today. Jess is a surgical trainee ST7 at Guy's and St Thomas, following completing a year at Homerton in bariatric surgery. And she's just completed a PhD at UCL with Professor Bataram, where her research interest was looking at weight regain following bariatric surgery. So over to you, Jess.
Hi everyone, good afternoon. I'm Jessica Mock, and I would like to thank the organisers for inviting me to talk on this topic, weight regain after bariatric surgery, etiology and treatment options. This was my research focus for my PhD at UCL, and I'm delighted to share some of my research and findings here today. Bariatric surgery is the most successful treatment for people with obesity in engendering marked, sustained weight loss with evidence of its effects over 20 years. And although most people achieve durable weight loss on an individual level, the response to surgery is highly variable. And at the moment, unfortunately, we cannot predict how a patient is going to respond to surgery. And for the individual, it could mean quite a big difference in their overall weight. This graph here plotted each individual patient following sleeve gastrectomy and gastric bypass. And as you can see, on average, people maintained sustained weight loss, but some people started to put on weight after 1 year. And importantly, some patients regained much of their weight that has been lost. And the prevalence of weight regain is reported at somewhere between 20 to 30%, depending on the definition of weight regain. Greater weight loss is linked to prolonged improvement and remission of comorbidities, diabetes resolutions, and a resolution of hypertension, obstructive sleep apnea is all dependent on the percentage weight loss, and therefore maximizing weight loss is really key to improving health. We know that obesity is a chronic condition and has now been recognized by the European Commission this year and describing it as a relapsing and progressive disease. And it is therefore not surprising that weight regain is prevalent after surgery. As with all treatment, be it surgical or medical, there is a certain relapse or suboptimal response rate. However, for the individual patient and healthcare professionals, it is often easy to forget. And often we hear blame on both sides, which can lead to patients becoming demotivated and failing to come back to follow up. And this is therefore, I think, vitally important for both patients and healthcare professionals to understand the etiology and treatment options for weight regain following bariatric surgery. These are the common themes that have been reported associated with weight regain after bariatric surgery. Genetics seems to play an important role in how patients will do after surgery. And this study showed that the increase in numbers of obesity-related alleles reduces the amount of excess weight loss achieved after surgery. And these may ultimately be driving the eating patterns and hormonal changes, which I will go on to talk about. Anatomical problems such as gastrogastric fistula, dilated anastomosis, and pouch have been reported as causes of weight regain. A gastrogastric fistula is communication between the pouch and the remnant stomach, which allow food to pass through to the main stomach and duodenum, and this change in food transit can lead to weight regain. The prevalence of this is actually quite low and very uncommon, and can be treated with surgical revision. Dilated gastrojejunar anastomosis after bypass can be treated now with transoral outlet reduction techniques using endoscopic suturing, and they've reported some promising results at 5 years. Dilated pouch sizes have inconsistently reported in terms of its effects on weight regain, mainly because of the lack of standardization of the definition of pouch dilatation. But the treatments and revision options are covered elsewhere in this meeting, so I will not go through this here. So moving on to dietary non-adherence and physical activities. Dietary non-adherence is common after reported with patients who have weight regain after bariatric surgery and can commonly start after 12 months. Some studies have reported change in eating patterns, such as increasing in grazing patterns, increasing in change in macronutrient intake, increasing excess calories such as and snacking and sweets and high calorie liquids. Treatment options here are nutritional counseling and encouraging patients to come back to follow up. After surgery, there's now a number of interventions looking at increasing adherence to follow up, including remote follow-ups, app-based interventions. This is the Swedish obese subjects study, which have reported again an increase in calorie intake after surgery over time and a reduction in physical activities after surgery with a 10-year follow-up, again demonstrating that eating patterns does change with time following surgery. In terms of exercise, we know that rapid weight loss immediately after surgery is often accompanied by a reduction in muscle mass, and this can lead to a reduction in resting energy expenditure. And if this is coupled with a reduction in physical activity, it can drive further reduction in total energy expenditure, leading to reduction in weight loss or slowing down of weight loss. The good thing is exercise intervention seems to work, and there's good evidence for those. Strength building exercise have good evidence behind them, and not only do they improve weight loss, but also improving bone health. At UCL, we have just completed a lifestyle intervention study where patients received enhanced nutritional and behavioral telecounseling, self-monitoring, as well as a 12-week supervised tailored exercise program. This study was conducted at UCL, Whittington, as well as Homerton, and will be due to report the results next year to see whether there is any difference in total weight loss, body composition, bone health, and quality of life. When we look at the psychology of eating, there is a big focus on eating behavior after bariatric surgery and its effect on weight loss. Certainly, the presence of maladaptive eating patterns have been shown in multiple studies to be associated with weight regain. And maladaptive eating patterns are common after bariatric surgery. And the LIBSS study with a 7-year follow-up have reported a high prevalence of maladaptive eating patterns in patients who have had bariatric surgery, ranging 10 to 30%. And they are present in 60%, 65% of patients who have displayed disordered eating. There's evidence that behavioral therapy helps, whether it is in person or remotely delivered or group-based therapy, with remote improvement in weight loss using these behavioral intervention after surgery. Metabolic and gut hormones is emergent as an important driver for weight loss after surgery. And just as a recap, following bariatric surgery, there is a marked change in gut hormones with an increase in satiety hormones such as GLP-1, peptide YY, oxytocin, marked reduction in hunger hormones such as ghrelin. And these together leads to a reduction in appetite, reduction in food consumption and energy intake. And therefore changes in patients' eating patterns and behavior as these are driven by these powerful gut hormones which act centrally in the brain. There is, however, a difference in gut hormone response following the bypass in the sleeve. As you can see here, patients who had the sleeve gastrectomy exhibited a much lower level of GLP-1 compared to the Romaine gastric bypass in all patients. And in those with poor weight loss, they have a lower level of meal stimulator satiety hormones such as GLP-1 when compared to those with good weight loss. What we don't know is whether these patients with lower levels of satiety or lower levels of GLP-1 and peptide YY also exhibit more maladaptive eating patterns. So in terms of treatment options, there are now more treatments targeted to gut hormones, and there are emerging studies looking at adding liraglutide, which is a GLP-1 receptor agonist, as an adjunct to surgery, and they have reported additional weight loss after surgery. In other countries, there are, such as the US, there are more pharmacotherapy options that are approved for use, and they have again reported to have beneficial outcomes when added in conjunction with surgery. So putting all these together, how do we manage a patient as a whole? And are there links between all of these contributors to weight regain? Well, my research looked to answer some of these questions, and I would like to share some of the results here today. One of our hypotheses is that in patients with suboptimal weight loss and weight regain, the presence of maladaptive eating patterns is associated with suboptimal level of satiety hormone GLP-1. We also think that there is a difference in mechanisms driving weight regain compared to the sleeve and bypass, and therefore they may exhibit different eating patterns, and treatment might therefore need to be tailored depending on their biology. For this study, we included patients who have had less than 20% total body weight loss at 1 year or more after surgery. We saw patients in a weight regain clinic. We screened them for eating behaviors using the 3-factor eating questionnaires, and invited them to participate in our trial where we did some meal-stimulated gut hormone profile tests as well as visual analog scores for their hunger. Here's some of the results which I will run through with you. Comparing the sleeve and bypass, as you can see, patients who had the sleeve gastrectomy reach weight nadir earlier and start to regain earlier compared to those who had the bypass. The degree to which patients' weight regain is also different, as you can see, in those with suboptimal weight loss. So all of these patients in these graphs have less than 20% total body weight loss. And in this cohort, a full weight regain can be seen in 25% of patients who had the sleeve gastrectomy, whereas patients who had the bypass regained to a lesser degree. This waterfall plot included all patients who were included in the study, and again, patients who had higher degree of weight regain amongst those with sleeve gastrectomy compared to bypass. When we looked at gut hormones, patients who had the sleeve gastrectomy exhibited a lower level of GLP-1 response, so less of the satiety hormone after a meal compared to those with bypass. But there were no difference in their subjective feeling of satiety when we used the visual analog score. When we put everyone together, so people with a sleeve and the bypass with suboptimal weight loss, we separated the patients who had high versus low GLP-1 response and compared those with the eating pattern scores. Here we found that patients with lower levels of GLP-1, so again, all of these patients had suboptimal or weight loss or weight regain. Those with a lower level of GLP-1 seem to have exhibited a higher level of uncontrolled eating, cognitive restraint. So in summary, we found that the weight regain patterns are different between the sleeve and bypass, and they exhibit different GLP-1 response. I didn't have the graph to show you, but that 75% of all patients who had sleeve gastrectomy had low GLP-1 response in this cohort. So perhaps additional GLP-1 receptors in these patients, such as using liraglutide, may be beneficial. And patients with lower postprandial GLP-1 response had higher levels of maladaptive eating patterns. We looked at all the studies looking into the causes of weight regain and poor weight loss. These are the main factors that we have found that have been most studied. And again, there is a big focus on eating patterns, eating behaviors driving poor weight loss. In the UK at the moment, the mainstay of treatment for weight regain is behavioral therapy and dietetic counseling, as we continue to struggle to offer revisional surgery and pharmacotherapy is currently limited. I think, however, that given that there is now emerging evidence that, as we have found in this study and also in other studies, that these eating patterns may be driven by biology, and therefore behavioral therapy alone is unlikely going to be as successful. So we are asking patients to work against their biology. And for those with suboptimal satiety hormone response, perhaps adding a GLP-1 receptor agonist is more likely to be successful. Also, earlier identification of weight regain may allow for targeted treatment and prevention of patients who may go on to suffer from a full weight regain. And taking into considerations of the different trajectories seen in sleeve and bypass, perhaps we need to act earlier for those who start to regain following a sleeve gastrectomy. And again, there's probably much more to learn in terms of other roles of other gut hormones, and perhaps revisional surgery could be based on the gut hormone profiles, aiming to reverse these gut hormone changes. Another part of our work at UCL looked at improving weight loss using targeted therapy based on their gut hormone profiles, and we're hoping to report these studies to you next year. So in summary, this is our proposed treatment algorithm, which is still a work in progress, but essentially involves assessing patients surgically, looking at their dietary and eating patterns, as well as assessing their gut hormones. And depending on the findings, treatment should be targeted. For example, low GLP-1 response may be treated with additional GLP-1, or we can counsel them for revisional surgery, aiming for those that we know increases GLP-1, for example, converting the sleeve to a bypass. And in those who have got adequate gut hormone response, treatment could be targeted towards looking at the dietary and lifestyle interventions. So in conclusion, weight regain is not uncommon, and as I think mentioned in a number of speakers in this section already, we need to set realistic expectations and work with the patient, and the key here is then multidisciplinary approach to treatment. Thank you very much.
Thank you, Jess, for that excellent presentation. I think I'm very excited to hear the results of Bari Lifestyle. And we do have a question. Is there any psychotherapy to control weight gain in the post-op period?
Sorry, could you repeat that again?
Is there any psychotherapy to control weight gain in the post-op period?
Yeah, I believe there's studies looking at cognitive behavioral therapy and acceptance-based therapy. I'm not a psychologist myself, so I don't know the ins and outs of these therapies, but there certainly is evidence that these kind of treatments help in terms of getting additional weight loss.
Jess, you have done excellent piece of work with gut hormones, and we know in NHS it is so difficult to measure these gut hormones. Do you think if they are more freely available, our patients might have a better course of progress after surgery?
Yeah, I think we need more evidence to show that measuring these gut hormones make a difference in our treatment. And until then, measuring these hormones are very expensive, so it's unlikely to be available. But we are getting towards there, and I think that in the future it will be a key part to treating patients.
Thank you.
Thanks, Jess. There's another question. Which team members should be involved in the decision making about the type of revisional surgery?
I think this is definitely a multidisciplinary approach, together with dietitians, psychologists, surgeons, and specialist nurses who know the patients well, and physicians looking at, again, medical and any contributing factors. And I think, as I said, alluded to earlier, I think that there may become more of a role of, depending on gut hormone response and what that is, that's tailoring the revisional surgery based on gut hormones, and that hopefully is going to be something that we will study more about later on.
Mm-hmm. And is funding likely to be an issue to prescribe GLP-1 post-operatively?
I guess depends how expensive drug company makes them, and NICE is reviewing that at the moment, and to see whether it's cost effective. I suppose with the new once weekly semaglutide, I guess, again, depending on the cost benefit analysis that NICE come up with, I suspect that hopefully it is something that will be available in the future.
Thank you.
Good question, Jess. You know, the obesity is multifactorial, so there will be, in my opinion, never like golden pill for that. There's also the element of, you know, bile receptors, very popular a couple years ago, and all those hormones and neurotransmitters. I remember Professor Rubino was showing that there is around 500 of those hormones synthesized by stomach. Only those couple are investigated. Do you have any data or orientations how soon after substitution of these hormones patients are rebouncing? How long that therapy is? Because we can add, like, you know, tablets, Saxenda to those patients, which probably the most successful will be the long-lasting medication.
Yeah, in the studies that have reported in people with obesity, so without surgery, and the long follow-up studies, they have seen weight regain upon stopping of these medications. So there's not the longer term study to look at really long-term outcome at the moment, but they do seem to be something that needs to be taken consistently for its effect. And going back to the other gut hormones, yes, definitely, GLP-1 is just a very small part of the whole picture. And the reason there is a sort of more focus on GLP-1 is that we do have GLP-1 receptor agonists that we can use. So actually focusing on that hormone it's a reasonable start. But as we have more pharmacotherapy options, and it may be that we will look at other gut hormones and also taking those into account.
Jess, do you think that we'll see a future where genetics will determine the choice of operation and hence less likely to have weight regain?
Yeah, absolutely. I think that there's a lot of work going on, actually, some work going on at UCL looking at whether different genetics puts people at risk of weight regain, and therefore some patient with certain genetics seems to work, do better with certain operations, but I don't think we've got the answer yet at the moment.
Thank you, Jess. Fantastic talk, and I think it's about time for the next speaker.
Thank you, Jess. Next speaker I need to introduce, and I want to introduce Dr. Manisha Sharma, my colleague, consultant chemical pathologist, bariatric lipid specialist. Manisha works in Homerton with our most complex patients and is contributing towards excellent holistic and comprehensive perioperative optimization and management.
Thank you very much.
Thanks
a lot. Thank you. Thanks a lot, Adam. Am I audible? Am I audible?
Yes,
and
Manisha,
can you see my presentation as well?
Yes.
Okay.
You need
Thank
to
you very much.
You need to actually share the screen, put it on full, the slideshow, Manisha.
Is it not full?
No, it's.
Can I just? I think I might have to stop sharing and then make it full. Just a second, please. So sorry, I was all ready and I don't know what has happened here. Can you see my presentation? But it's again.
Yeah, I just need to start it on the slide.
Yeah. Is it full screen now?
You just need to, yeah, it's now, yeah.
It is now, yes.
Perfect.
Thank you so much. Thank you, thanks a lot. Thank you for bearing. I wish to thank Mr. Sanjay Agrawal for inviting me for this talk and all the organizers. And thank you so much to the chair, all the chairs and moderators. Yesterday, I talked about the preoperative nutritional challenges. Today, I'm talking to post-operative nutritional challenges, which are which we face in our practice. And Homerton being one of the most busy units in the UK, we see a lot of complex patients, duodenal switch, mini gastric bypass, sleeve gastrectomy, gastric bypass, and banding as well. So this is a very familiar diagram just to show all these surgeries. We have got follow-up patients and all these surgeries are done. And just as Aparna said in the morning, a lot of post-op nutrition and post-op complications are based on maths, which is 2 + 2 is 4. Whichever part of the surgery of the gut is bypassed or is removed, it's a calculation. And what we expect is actually very simple if we understand the nuances of the gut and the surgeries. So it's always good to know the type of surgery. And we all work with a field where we have overlapping interests. So I want to know more about dietetics, and dietitians would like to know more about, and nurses would like to know more about blood tests and interpretation. So just a pre-word, as patients come to us, the post-operative dreams of our patients, and it is very eerie. You can actually think they can have really nice dreams, and some people are even going into surgeries because they have got a dream which has never been fulfilled of going into a relationship, and they have all the right to have all these dreams. But what some of them land into are all these complications, and sometimes they can have more than one of all these complications, and it can be a really, really sad part. But the best part is that all the AHPs and physicians and people who are involved in the post-op care can avoid all these complications and give the benefit of the surgery, this beautiful piece of work which is done by surgeons, by adequate follow-up, and by actually, before I go about adequate follow-up, by the resources which should be available in every center to help that post-op care. These are two cases which are when we show these pictures, they look beautiful. So one patient had duodenal switch with a common channel of 75 centimeters. So if you can see, this is the first picture, and then this is the last picture. She's very happy. Yes, she had a rough patch where she had night blindness for 1 year. She could not do work. But then we got vitamin A since, thanks to Mary, we got them approved in our founder by the staging injections regularly to her and many other duodenal switch patients, and she's doing absolutely fine. She's very happy. Even her daughter had the surgery. Another patient, looking at this picture, you can see she must be very happy. But this patient, she struggled with vitamin and minerals compliance. She had psychological issues, and she also wanted to reverse the surgery. So again, we can see that on the periphery, you can see fantastic results, but what goes on inside a patient body and mind, and probably soul as well, is very difficult to ascertain. And that's why we need a very comprehensive team. And like we have seen since last 2 days, all the different members, they bring different tangent to the experience of a patient and how we can help these patients together. So coming to my first case, 39-year-old female with a BMI of 61, with diabetes, hypertension, severe obstructive sleep apnea, underwent duodenal switch surgery 4 years ago. After the surgery, BMI came down significantly, as you can see, from 61 to 34, and her comorbidities resolved. But she was lost to follow-up for 2.5 years, and she had loss of 7 teeth and 2 tibial fractures during this period. When we did the blood test, she had anemia. Her ferritin was very low. Vitamin D is low with a high PTH, which is understandable, secondary hyperparathyroidism. Calcium is low, understandable with low PTH. And I did alkaline phosphatase isoenzyme, which we discussed yesterday. So alkaline phosphatase is a liver function test, but when you do isoenzymes and if the bone component is high, that suggests that there is too much of bone resorption, which is happening under the effect of PTH. So this patient had too much of bone resorption, which explained her teeth and bone problems. We can do more markers, but at Homerton, we try to do the bare minimums. Otherwise, there are biochemical markers of bone formation and bone resorption, but we didn't need to do them. So this patient, again, B12 is something which I have been hammering about for many years. The B12 looked normal as per the reference range, but the active B12 or holotranscobalamin, which is the active moiety and available to the biological receptors, was much low. MMA, a marker of functional deficiency of vitamin B12, was much high. So this patient had severe functional B12 deficiency. The patients who are at high risk of B12 deficiency, again, when we do bariatric surgery, sleeve gastrectomy, gastric bypass, or duodenal switch, in which sleeve gastrectomy is usually the first part, it's a surgical form of creating pernicious anemia in a patient. We have to all understand that we are creating a iatrogenic pernicious anemia. Plus, any patient who has got any of these additional factors, that is even more double insult. So vegetarian and vegans, drugs, a lot of patients can be on metformin, proton pump inhibitors for reflux, and these are less common. These drugs, they increase chance of B12 deficiency. Again, a patient who has got other features along with bariatric surgery, they have got double component. H. pylori infection is not uncommon. And B12. So folate and B12, the complex relationship. Folic acid is something that is freely available in the market, and there has been too much news in the media. So every young female who has been wanting to conceive, they start folic acid supplementation on their own. And especially I'm seeing a lot of patients who are going abroad to countries like Egypt and Cyprus and Turkey, getting their surgeries done, coming back with no follow-up in the GP care. And they can have such complications where they are overdoing folate, which aggravates B12 deficiency. So our guidelines specifically, led by Mary, they say that folate should not be given in patients who have got B12 deficiency. And again, what we have to keep in mind that a patient with a B12 of 300, 400, 500 would still be B12 deficient. So a patient on folate, try to keep the level more than 500 to 1000, depending on the reference range of the lab. This is a common slide which most of you might have seen before. Forgive me, but I love this slide because we have a bigger audience this time. And although it might be repetition for some of you, but maybe new for the new ones. So when we have low B12, why B12 is important? We have all read in our medical or any specialist area primary schooling that Krebs cycle is extremely important for ATP generation. 1 molecule of glucose releases 36 molecules of ATP in aerobic respiration. And this only happens if there is B12 manifest, if the B12 is there, to convert methylmalonyl-CoA into succinyl-CoA, this particular step. If there's a blockage here because of B12 deficiency, MMA accumulates. So that's why we get high MMA in a B12 deficiency patient. Plus, because the Krebs cycle is not that efficient, ATP generation is less. And you can imagine ATP is the energy source. Every cell, cardiac cell, nerve cell, skin, every cell needs ATP for growth, proliferation, and rejuvenation. And that's why B12 deficiency affects each and every system of the body. As you can see here, brain, impaired cognition, depression, neurological features, patient can become infertile, bone marrow, anemia, breathlessness, and anemias, cardiomyopathy, and peripheral signs. And not only that, in addition to B12 deficiency, patient can have other cardiac problems, and when they combine together, they can form a lethal combination. So this patient had severe vitamin D deficiency with secondary hyperparathyroidism, high bone turnover as suggested by 80% bone ALP, with risk of low impact fractures and poor bone metabolism, which we saw. This patient also had coexisting iron and vitamin B12 deficiency, which aggravated dental loss. So B12 is a growth marker. Iron is required for hemoglobin for oxygen carrying capacity. And when all of that is compromised in the jaw, then the patient will have, he had vitamin D, iron, and B12 severe deficiencies, which led to periodontitis due to multifactorial reasons. So I even talked to the dentist and they said all these features contributed to the poor health of the patient. So what we have to realize that if there is one deficiency that is less dangerous, but multiple coexisting nutritional deficiencies are more dangerous, and they impact in such complex ways that it can make the clinical picture quite deceiving. So this patient had aggressive therapeutic parenteral treatment of vitamin D, 300,000 IU/IM injection followed by 20,000 orally twice per week. And then B12 supplementation, 7 injections over 2 weeks, followed by 3 monthly shots. Very important, our BNF in the UK says we can give, every day we can give 1 B12 injection till the neurological features clear. But I usually in my practice don't do that because sometimes serial injections every single day can lead to hypokalemia, low potassium. I have a case further ahead where I'll reinforce this. So alternate day, and especially in elderly patients more than 65, anybody with a cardiac problem, do not give B12 injections every day, give a gap of 2-3 days in between. This patient had a bone turnover with decreased bone ALP with symptomatic relief, and so patient did well. No further tooth loss with improved dental condition. Energy levels were better, and the patient is still under the follow-up clinic. This is a case which I have shown on every platform, and the reason I repeat it because it shows how severe things can go if they are overlooked by the patient, or if the patient is lost to follow-up and we are not able to track them back. So this was a 51-year-old severe sleeve gastrectomy and gastric bypass patient who was operated elsewhere, not at Homerton, and had a very poor drug compliance. And this patient was an inpatient for 16 months in 2 different hospitals in the UK. So 16 months was hospitalized. She was treated for Wernicke's encephalopathy with ongoing Fabry-Nex. She had worsening depression and wheelchair bound for 3 years due to neuropathy involving feet. So her both legs were like this, and she could only touch her toes, her heel. So she had a lot of spasticity in her muscles, in her leg muscles. So she was referred to Homerton Bariatric Specialist Unit. And this is one case which highlights how multidisciplinary teams, AHP teams, surgeons and physicians and psychologists come together and can actually make a huge difference. So this patient had positive finding on neuromuscular examination, had proximal muscle weakness, bilateral spastic paresis, proprioception, she could not feel touch and vibration. There were absent deep tendon reflexes, and she was unable to stand. When I did the blood test, she had very low ceruloplasmin. So ceruloplasmin is the copper carrying protein in the serum. This is usually available in the labs, in your routine NHS lab. So probably if you're not able to measure copper, you can ask the lab to measure ceruloplasmin. MMA, as we discussed, MMA was very high. But as you can see here, B12 was 260. So with a B12 of 60, nobody will think that this patient might have B12 deficiency. But because there was a strong clinical suspicion, I did MMA, and holotranscobalamin was borderline, but with a high MMA, I progressed further. Vitamin D was fine, thyroid function was fine. So with trace metals, and I also did thiamine because she was being treated with Pabrinex, so I wanted to rule out thiamine deficiency, and which is not easily available, but yes, being a chemical pathologist with a very supportive team at Homerton, I could do it. So the copper was very low and selenium was also low. Zinc and vitamin A were fine. So this patient had severe functional vitamin B12 deficiency with folate overdose. Folate was something, for some reason, this patient was not taking any supplements. So but she was overdoing on folate for some reason. When she told me later that she had severe deficiency when she had her children. So with folate, she was fixated, and that further compromised her B12 deficiency. She had severe copper deficiency, selenium deficiency, and depleted iron stores. So all folate supplements were immediately stopped. B12 injections were given as per the therapeutic regime for neurological complications. Thiamine injections were stopped. She was given copper IV infusions, multiple with careful monitoring. I have not mentioned here, but she also had kidney stones and a stent. So we had to be careful about her renal function because copper is a heavy trace metal. So we were looking after that aspect as well. She had high doses of oral multivitamins with selenium and iron and increased protein intake. And with this one patient, the whole team was heavily invested. So this patient had marked neurological improvement, proprioception gain, and patient could walk with crutches after 3 years. And there was intensive support from our physiotherapists, nurses, dietitians, to an extent that this patient could walk after 3 years, and her borderline personality disorder diagnosis was reverted. It was mainly because of her nutritional deficiencies. She moved on to an independent accommodation and even won a Slimmers Award of the Year for a weight loss organization. And now she walks without any support. She came 2-3 weeks, so she comes and sees me every 3 months. And she's currently having age-related health issues, but never had any severe nutritional deficiencies again. So again, a case to highlight robust vigilance by the patient and the AHP team as part of long-term follow-up, and to alert the physician and the surgeons whenever needed is absolutely important. Another case, 70, and I'm presenting these duodenal switch patients because I get most of them. But again, I see some gastric bypass and other patients as well. And the examples that I'm showing, they can be present in any of the bariatric surgery patients. 71-year-old male with duodenal switch surgery under follow-up care came to the clinic and informed that he was admitted in local hospital due to a lot of palpitations and was diagnosed to have atrial fibrillation. So this is a new diagnosis. He was found to have hypokalemia, which is low potassium level in the blood, and was given potassium supplements from in the local hospital and was discharged on ongoing supplements. So this patient he was on diuretic water loss pill, and because the diuretics, they act with the function of the person is made to pee more sodium, and because of which the water loss happens and the swelling in his legs would reduce. But they also cause electrolyte loss like potassium and magnesium as well. So because this patient developed hypokalemia for unknown reason, they reduced the dose of the diuretic, and he started feeling breathless. When a patient has swelling and sometimes if there is edema, he can also have cardiac overload. So this patient started breathlessness and exertion on walking, and the legs started swelling again. The medications this patient was on: furosemide, lansoprazole for reflux, allopurinol for gout, vitamin and mineral medications related to bariatric surgery, all of them, and including calcium supplements. His drug compliance was very good because I have been following up him since the beginning for last 8 years. So this patient had slightly high ALP. Again, when we say alkaline phosphatase, what I want you all to remember that ALP can be from liver or from bone. When a high ALP is there, please think, is there a vitamin D deficiency or PTH high, which could be contributing to this high ALP. Corrected calcium was low normal. The range is 2.2 to 2.6. Magnesium, low normal range. Vitamin D was low and PTH was high. But if we compare these from the previous levels, this patient, the potassium was 4.1 here and 3.4. So it is still coming down. And I had a feeling, if this patient is on potassium supplements, is this a genuine result? And I had a question, so this is a new case of atrial fibrillation. Is there anything related to bariatric surgery that can contribute adversely to his atrial fibrillation? Because we know our GPs, our other specialists might not know much about bariatric surgery despite all the efforts that are being made. So it's also our duty to empower other clinicians and increase their awareness what a bariatric surgery can contribute in. I asked patient about any significant medical history change in diet. He had a long spell of diarrhea, which tells that he might not be absorbing his vitamin and mineral medications and other supplements. And currently on PPI loop diuretic. So here, if you see, diarrhea can give loss of potassium from the gut. PPI, they cause hypokalemia and they also can bring down your magnesium level. Loop diuretic, a diuretic which is making you pee sodium, but also can make loss of sodium, of potassium and magnesium. And too frequent B12 injections. When B12 injections are given too frequently, so B12 is a growth marker. You know, there are bone marrow changes because of B12. Anemia happens because there is an asynchrony between the DNA and cytoplasmic maturation. So B12 injections kick in the formation of red blood cell precursors in the bone marrow. But that happens because it uses potassium from the serum. Because if we remember, a cell has got more potassium inside and intracellularly and sodium more outside. So vitamin B12 injections like insulin can cause influx of potassium into the cells, which leads to dropping of potassium levels in the serum. So he had multiple factors here which were causing low potassium. And plus the diarrhea because of the duodenal switch surgery, which was further aggravated possibly because of a subclinical infection or because of duodenal switch. There were multiple factors here. So, and again, magnesium is required for potassium levels to be maintained for ideal renal handling. Then this patient also, what I wanted to figure out, because lab plays an important role in clinical management of patients, and because of being able to work in the lab, I understand the complexities there. So I wanted to know, is this potassium result reliable? Because he was on potassium supplements and still the level was 3.4. And when he came to the clinic, he didn't look very well. His heart rate was still high. So I called the lab and called the duty biochemist. On that day, I was myself the duty biochemist. So I asked the lab, but you can do it by just calling the lab and asking them to see if the sample is still there, if it is within last 4 days, if it was slightly hemolyzed. Anytime if it's a poor technique or a sample has been manipulated, in the sense it has traveled from in a chute and it's slightly hemolyzed, potassium leaks out from the cells and can increase the potassium level in the serum artifactually. That's not genuine. Now, calcium was low in this patient, and I asked the lab, another thing which you want to know is that, yes, there are a lot of steps and checks which are done in the lab where a genuine result is released. But sometimes some assays can have a negative bias or a positive bias, which is acceptable as per monitoring. But if you see a big fluctuation in a patient in some of the levels, you can always pick up phone and ask the duty biochemist. So because of the hemolysis, I felt probably the potassium was even lower than 3.4 despite the supplementation. So we repeated the test. The patient had low normal magnesium, low potassium. So he was again put on potassium and magnesium oral supplements. I also wrote to the GP. I also wrote to the GP to consider potassium sparing diuretics. Because of the reduction of dose of the diuretic, his legs were swelling. So he needed some diuretic, but not something which can again make him pee more potassium. So there are other potassium sparing diuretics which make a person pee sodium and water with it, but they are, by nature, they are called potassium sparing diuretics and they can be considered. But the GP has to make that decision. And I advise patient to be careful before vitamin B12 injections and defer the injections if he has episodes of diarrhea. Also advise him to have potassium-rich food, but we have to be careful in patients who have got any impaired renal function because we cannot ask them to have potassium-rich food. This patient had normal renal function. And again, so clinical correlation of all test result is absolutely important, because looking at a potassium of 3.4, I could have missed it. But because this patient didn't look well, his heart rate was very high, it felt like that he was still not completely resolved for his AF. And also we have to keep in mind biological and analytical variation of biochemical parameters. Anytime if in doubt, you can ask the duty biochemist. They are always holding a bleep and they will be happy to answer. Next case, 53-year-old Asian lady, BMI of 43, presented to A&E with palpitations and tightness in the chest. History of sleeve gastrectomy 28 days back, lost 4 kgs since surgery. Other comorbidities prior to surgery were hypothyroidism, was euthyroid on 200 micrograms thyroxine prior to surgery. High blood pressure, diabetes, arthritis were other issues. So this patient had a free T4 of 45, very high. TSH suppressed. So this patient is hyperthyroid, and corrected calcium looked a little high. Troponin was normal because she had chest pain, but her troponin was normal. Even serial troponins were normal. ECG showed sinus tachycardia. Thyroxine was stopped for 4 days. 4 days because the half-life of thyroxine is 3 to 4 days in a hyperthyroid state, because the metabolism is so fast, thyroxine can be, the level would come down in 3 to 4 days. Then slow titration of thyroxine was done, starting from 75 micrograms per day, and patient became euthyroid on 125 micrograms. So prior to surgery, when the body's need was 200 micrograms, after sleeve gastrectomy, the requirement reduced. And there are publications around it. One from our colleague, Mr. Sanjay Agrawal from AIMS in New Delhi. There are some publications already, and we need to do, but we see it very often now. So patients, this patient had palpitations, chest symptoms, but they resolved after when thyroxine dose was reduced. Regular monitoring of thyroid function has been done, and the patient was referred to cardiologist for further evaluation in case he has got any atherosclerosis, which is compromising his cardiac condition. But his condition got aggravated by hyperthyroid state. So we know pharmacokinetics of levothyroxine, it improves after sleeve gastrectomy and DS patients, and they require careful monitoring and dose adjustments to prevent acute complications. We have a local policy of testing thyroid function test 3 weeks after every sleeve gastrectomy patients in patients who are on thyroxine. Again, clinical correlation is very important. Something I will just like to mention, heterophilic antibody interference in immunoassays. You don't need to know about all these details, but anytime if a thyroid function, like something so excessive, a very high free T4, very high free T3, or a high TSH, which doesn't clinically correlate with your clinical condition, please talk to the lab, because there are some antibody interferences which can give confusing results. And in that case, a sample has to be sent to another lab with a different immunoassay. So these are limitations of immunoassay, which the biochemist will be happy to help you. Next case, 60-year-old female patient with duodenal switch surgery 8 years back. Other comorbidities, past history of unprovoked PE and on warfarin. Presented with history of easy bruising on low impact injuries, which progressed to spontaneous hemorrhage without injury. INR was elevated to 5, and she had been on holiday with very irregular dietary patterns. When I checked her vitamin K and PIVKA, so her vitamin K was very low and PIVKA was very high, suggesting functional deficiency of vitamin K. PIVKA is another functional marker like MMA for B12 deficiency. PIVKA is the functional marker for vitamin K deficiency, and this patient had markedly elevated. Prothrombin time was also increased. So this patient was given IV vitamin K injection and then was given oral vitamin K supplement for 30 days. And she had repeat level, which came back as normal. Her bruising improved and INR also improved. So every now and then, because of the fat-soluble vitamin deficiency, this patient is put on vitamin K supplements, and then I keep monitoring her. Again, I collaborated with the anticoagulation team at Homerton, because what we have to, one of the things which we encounter as a busy bariatric unit in Homerton, that we feel that Homerton, our clinicians are still other specialist areas. They see bariatric surgery patients very commonly, so it is more familiar to them. But other hospitals, it might be a very tricky situation where bariatric surgery and the associated complications are not very easily known. And that's why even in our hospital, I talked with our anticoagulation team, and they were very open about creating information for the patients, so that the patients who are, because anticoagulation, they are asked to have a low vitamin K diet. And here we are saying that our patients, they have got vitamin K, fat-soluble vitamin deficiencies. It's a very confusing picture, and that's why patients on anticoagulants, they have to be really careful. And it's good idea to ask patients if there are any anticoagulation team, and probably writing to them to be aware of these fat-soluble vitamin deficiencies and vitamin K to prevent any such occurrences of hemorrhages and bruises. Another patient with Roux-en-Y gastric bypass 3 years back with starting BMI of 44 and type 2 diabetes mellitus, hypertension, obstructive sleep apnea. Post-surgery BMI of 33, and patient was off all his medications and CPAP as well. So he had recurrent renal colics, passage of calcium oxalate kidney stones. He had history of long-term AdCal D3 intake. When we investigated, we found he had severe vitamin D deficiency with high PTH. 24-hour urine collection showed very high calcium excretion, increased oxalate excretion, and low citrate. Citrate and magnesium, these are two components in the urine which are stone inhibitors. So usually what happens in urine, we have stone promoters and stone inhibitors. There is a fine balance of stone inhibitors and promoters. And when the inhibitors are less, like citrate is less or magnesium is less, there is more chance of precipitation of calcium particles or calcium oxalate in bariatric surgery patients over the small nuclei, and the stone can grow bigger. So these patients we have to be very careful, because we know gastric bypass and duodenal switch surgery, by the mechanism, they increase enteric hyperoxaluria. So oxalate is absorbed more, and any calcium that will bind with it, it can form calcium oxalate stone. So we have to be very careful with these patients. And AdCal D3, which has got calcium carbonate, is more prone for calcium stone formation in our bariatric surgery patients and even in general population. So with bariatric surgery patients who are high risk for enteric hyperoxaluria, we have a local policy. We don't give AdCal D3. We advise patients to have calcium-rich diet or calcium citrate. And calcium citrate is not easily available. It's not available in NHS, so they have to buy it online or local health shops. And this patient was given high dose of vitamin D injection, calcium-rich diet. It's a paradox. We all know it because it has been mentioned several times. Calcium stones, patients with calcium-containing kidney stones should not have some specific calcium supplements, but diet should be high in calcium. And they should have a low salt diet, very important. High water intake, 2 to 2.5 liters of water. And again, it can be even more in patients who are losing a lot of water in diarrhea, especially with gastric bypass, mini gastric bypass, and duodenal switch patients. So it's important to have a customized advice to every patient and not a generic one, depending what is the water intake. If a person is having diarrhea 10 times a day because of duodenal switch or mini gastric bypass, they will have to have more water to keep their urine dilute and prevent precipitation of calcium-containing kidney stones. Low oxalate diet and DASH diet, again, a low salt and low oxalate diet, very frequently used by kidney stone clinics. So we can even guide our patients to check on the sites where they talk about kidney stones. These are the guidelines. Again, gratitude to Mary O'Kane and other specialists who gave me the opportunity to contribute to these guidelines, which are absolutely beautiful, and hopefully they will change the face of bariatric surgery patients' follow-up care everywhere. These are the other biochemical and metabolic issues associated with bariatric surgeries, which we can see in our practice. Yes, I have. So the cases, I have finished with the cases. As a summary, which I want to reinforce, and as a plea, I want to share my thoughts. Positive clinical outcomes post-bariatric surgeries govern increased referral rate of surgeries, allowing more patients to get the much-needed surgery. Bariatric surgery is life-saving and life-altering. Many patients would be very unwell or dead by now if they did not have bariatric surgery. We all know it. But we need to constantly reinforce when the patients are complaining about lack of energy and other problems, we have to make them realize that they have not suffered a heart attack, they have not suffered a stroke, they have not developed a cancer or a DVT because their weight has come down. The inflammation in their body has come down so much, we have to constantly remind them. When they talk about excess skin and lot of things, we have to remind them of the things that they have been saved from because of the surgery, the metabolic complications which never happened. And we also need to consider the chronic conditions and the age-related conditions that will crop up with age, because somehow it is there in the head of the patient or the physicians or the general practitioners who are looking after that. Probably everything is related to bariatric surgery. There are age-related comorbidities like osteoporosis, other health issues. Like 2 weeks back, I had a patient who had a primary ovarian failure. She had a coil and she had a primary ovarian failure, which was never picked up. And we know it has happened because of her genetics or because of other health conditions. But then the initial thought comes in a patient that is it malnutrition because of the surgery that she will never be able to conceive. It's a very sad thing, but we have to be open-minded, and we discuss with the patients that it is not everything that is because of the bariatric surgery or osteoporosis, osteopenia, age-related, menopause-related things. And I want to leave you with an analogy. I saw some surgery videos yesterday which made me think, because we all in different units, we see different things. And I'm not saying this as a patriarchal thing, but if I say surgeons are the fathers, in the sense that a mother always gives X chromosome to the baby, but father gives either X or Y chromosome, so creating the gender. Then if surgeons are the fathers, AHP teams are mothers, nurturing very closely, very heavily invested. And that's why sometimes they feel, they are not able to do everything that they can do. And a close bond in both with more robust communication, with conscious awareness is needed. Because yesterday watching those videos, and then I have the privilege of working very closely with our HP, a fantastic AHP team, and with our surgeons. And I can do most of the work because I have got huge support from our dietitians, nurses, physiotherapists, Jen, and Tamara and Emma, everybody, and psychologists, Mel and Max. I can do my work because I have got huge support from these and our surgeons, our very competent surgeons. But it is important to know that the challenges the surgeons face and AHP team face are so different and incomprehensible unless one is in each other's shoes. And I happen to sit outside a little bit and see both. And but I can see that we all try to do for best for the patient, but the perspective can be different. So a close bond, robust communication, and most of all the resources. We all struggle with resources in NHS in the UK. I hope in other countries it is not that much. So, but we are all committed to serve these sad souls. No one of them consciously wanted to be diseased or have low self-esteem. All of them, like any normal person, would want to go to the discotheque and have a nice relationship. So it was never intentional. A large number of our patients, when they confide, most of them seem to have, in my practice, 80% of them seem to have history of childhood sexual abuse, domestic violence, bullying, drugs, sibling rivalry. So what I want to say is, I'm just grateful to you, each one of you. You are touching lives, not one life, hundreds of lives attached to one person. And I just bow to you for your utmost compassion, because obese people, they can be big in size, but very fragmented and need a lot of love, care, and healing apart from medicine and apart from all the medical care. Just my acknowledgements to Mr. Sanjay Agrawal, all my lovely bariatric AHP teammates, and my surgical colleagues, all physicians. Homerton is a lovely place where it's a different environment. My colleague, Dr. Jeffrey Parent, and my Mehvish Khalid, my lab colleagues, and all seniors who support, because without them, I will not be able to do any of the blood tests and complex blood tests which they do. And you'll be surprised, these lab staff, they are always so happy when they know about a story, and I'll be discussing these cases with them when I go back. And last but not the least, my bariatric surgery patients who had kept their trust in me and allowed me to do certain things where we do not even have the guidelines, where we, as a clinician, I'm just going by the experience and doing certain things and monitoring them very closely. Our IT expert and Venkatesh, Danish, and Ravi, you have done a fabulous job. Hats off. Thank you so much, everyone. And this is just to make you laugh. These are my lovely chemical pathology colleagues who are behind the screen heroes, because they never get to see a patient, but I try my best to bring them to my clinic. And they have worked very, very hard in COVID pandemic, because we were even doing the COVID testing in the lab. So these are the unsung heroes, and they have my utmost respect. Thank you so much, everyone.
Thank you, Manisha. Couple questions. Manisha, your presentation really highlights importance of follow-up in nutrition bloods. How do we ensure commissioners understand this importance of access to long-term annual review and also supporting access to appropriate vitamin and mineral supplementation?
Thank you for that question. I think what we have to do is people who are in prominent position, and I look up to Mary, Itka, Tony, and other leads, and we all combine together and we go to commissioners and talk to them because the evidence is all there. And this is long awaited. We need to do it because the complications are arising, especially in NHS. We see where even like waiting times of all clinics have increased. And also, if there is more education of the patients, if we can empower them, and like I say it again and again, Mary's document, if it can be done in a easy language for patients, that will empower the patients and they will be more in control. So I think this is an area where all of us have to come together and do more work, and that will help.
Another question. If more patients are getting operations abroad, shouldn't GP have more awareness of the problem that could lie in wait?
Absolutely.
Should that be part of the training?
Absolutely. I have. This is a area which scares me because I do lipid clinic as well, which is completely unrelated to bariatric. But I see some patients who I have picked up that they have gone to countries like India, Turkey, Egypt, nearby countries. They did bariatric surgery. They came back, and when I was screening them for hyperlipidemia and familial disorders, their blood profile gave me a suggestion that probably they have a bariatric surgery. So I poked in them, and then they told me that they had a bariatric surgery. Patients do not have idea what they are stepping into, and probably other places where they are going to some centers who are doing surgeries for very small cost, but not giving them any pre or post-op much required information. And you will be surprised. Last year in one conference, I said I have seen 3 patients. Now I have seen 7 or 8 patients who, because of my rapport with them, they told me that they have done the bariatric surgery, but they have not even told their other half. So GP is very far-fetched question. And I had to almost plead them that they should tell, because I had to scare them that what can happen. This is what is happening when people have become depressed, lonely, wanting to have a relationship, and with the stigma attached to body image and all those things, what it has done to human psyche. It's scary. So yes, GPs and patients, everybody needs to be aware. Bariatric surgery is not an easy fix. There are requirements pre and post-op and lifelong follow-up.
Another question. I wonder if it is realistic to expect this level of post-operation surveillance across the board. Manisha, you are outstanding, but a specialist in biochemistry, there aren't many in the UK.
See, I think I have been humbled by the comments and the words mentioned about me. But I must say, I'm just lucky to be in a place where I have got excellent surgeons and AHP teams who are very supportive. And I think, see, chemical pathology and clinical biochemistry department is everywhere. But I think the awareness, but yes, there are less chemical pathologists like me who are interested in bariatric surgery. I have a personal and professional reason to be here. But you can always pick up phone and ask the duty biochemist and take advice, and probably more people will be interested to support the bariatric surgery units.
And last question, Manisha, some questions. One is about who orders and checks the routine bloods in our team. Sometimes this is left to AHP specialists who do not necessarily have the skills to interpret the results.
I agree. AHP teams in worldwide, they are expected to look after bloods and interpret, which is a very tricky place. And probably when I was a registrar in training and I saw I wanted to come to Homerton to support our AHP team, our bariatric surgery team as a chemical pathologist. We here are in Homerton, our dietitians and nurses order the blood, but the blood list and everything has been given by me. And they are very well trained and they are excellent. And very rarely, if they have a question, they ask me. But again, I would suggest to all the AHP team specialists, seek help from your hematology on-call duty person or biochemistry, and they will be able to advise you. Probably slow and steady, that's the way you might be able to increase the awareness of bariatric surgery among other specialties where they would be interested, because it's a novel area. New things which were never taught in medical curriculum or nursing curriculum, they are there. So I have even talked to one of our professors who is responsible for the BARTS health medical curriculum, that they should include a mandatory curriculum for bariatric surgery, pre and post-op complications, because our junior doctors need to know. Doctors working or dietitians or specialists working in A&E, they need to know if an unconscious patient comes, because it's only when the scan is done in radiology and suddenly the radiologists see altered gut anatomy, and then there is a suspicion.
And the last question, what is the safe limit for calcium in diet and medication to avoid the oxalate formation?
See, the best way for calcium oxalate stone prevention is, and I have suffered from calcium, from kidney stones 5 times, 5 surgeries. So I can tell you from a doctor's experience and a patient's experience. Only thing is 2.5 liters of water every day, cutting down on oxalate food, so cutting down on chocolate, rhubarb, soya, bran, what else? So all the food items, very majorly. Anytime you're having a oxalate-rich food, eat it with something that has got calcium, like paneer with spinach. Keep a balance, because the calcium in the food binds the oxalate in the food and prevents it from being absorbed. So any oxalate food, if you are ever having, eat something which has got calcium. And calcium supplement, don't give calcium carbonate to patients. And you have to be careful about things like Gaviscon, which can have calcium carbonate, and give calcium citrate if possible. So the safe limit for calcium in diet, say 1000 milligram. And in terms of calcium citrate for duodenal switch patients who have very severe malabsorption, I keep them on 1500 or 2000. But gastric bypass, you can keep them on dietary calcium plus 1000 milligram of calcium citrate.
Thank you, Manisha. Thank you to all. I think that's the time to finish our session. Thank you for excellent presentations on high level. Thank you for chairs for participation and leading this session.
Thank you very much, Adam. Thanks a lot. Thank you, everyone.
From London, and good evening. Thank you.
Thank you very much.